So if you see at that time, there's just before that, it'll pop up. It's just hard. We went there without any breaks.
Done that in Egypt.
Yeah. Another 5-star show.
No, you can use that one for like where you can catch this. This one. Tell me when you're ready and I'll play it.
Good morning, everyone. Great. Dr. William Welch. I'll be moderating this section this morning with Dr. Zamorano. Just as an announcement, this is the American Academy of Neurological and Orthopaedic Surgeons. And the Academy has designated the International College of Surgeons annual meeting update as its annual meeting. We work closely with members of the International College of Surgeons and the Academy to determine professional practice gaps and educational needs. And the planners representing these two major surgical specialties are developing 2 days or have developed 2 days of programming specifically for those interested in these fields. Participants in the first session will receive valuable updates on the diagnosis and most advanced treatment options for a variety of neurological and orthopedic conditions. And learners will have a better understanding about the latest treatment options for pediatric wrist fractures, hand surgery, anterior lumbar surgery, non-fusion stabilization devices, robotics, and neurosurgery, and creating ancillary income. Learners will obtain information to appropriately determine whether further more advanced educational initiatives are required in order to effectively implement the provided information into practice. So just I encourage everybody here, everybody attending this to, number one, submit abstracts for presentation for next year, and perhaps encourage your friends to submit for next year. We're on the East Coast next year, Philadelphia, which is my hometown. So I look forward to seeing everybody there. And these sessions are always very meaningful for me. I always learn a lot with these sessions. The talks are 20 minutes, but we have until noon. I'd encourage everybody to hold questions till the end of the talk. I'm going to ask questions. I know I always do, and I hope everybody else participates fully and asks questions. Is Dr. Ramathula here? First speaker.
I haven't seen him yet.
No. Okay, let's go to the second talk.
He might be running late. I would go to the next person.
Yeah. Nick, is there anything else you want me to say?
No, I think I covered it well.
An introduction.
You covered it well. I texted Dr. Zamorano. I suspect she's probably on the call or something.
Dr. Sears not here.
Mark, are you ready?
I am. Good. Sheet up.
Not yet. You want to get it? Or?
Yeah, I can get it.
Okay.
It's a lavalier, so it's a wireless one, so you can put it. Yeah.
What's up, kid? Good.
Maybe so. Well, welcome everyone to our meeting this year. Everybody has been enjoying AANOS. It's a lot to do here, obviously, and all very successful. Wish you guys a very successful stay and successful meeting. We have there have been some changes in the program, so we'll start with a presentation from Mark, the everybody knows him, and we'll start our day with the controversies in the care of pediatric wrist fracture. Mark.
This talk, can you hear me okay with this mic here? Okay, right. This talk was originally going to be given by Katie Yoon, who you all, most of you probably know, from the ex-director of the incision group, and she's ill. So I'm going to present for her.
I can't hear you, Mark.
Is that my fault? How about now? Can you hear me in the back now?
It doesn't sound like it's coming from the mic though. No.
I think there's a button to turn it on there. It just turns on and here. There's no button there, is there?
I
Let's see.
thought Dr. Zamorano's was. There's a mute button.
Yeah, I've got a new button here, but if you, it's that muted. Okay.
How about now?
There's no microphone on. I hear your voice.
How about now? All right. All right, controversies in the care of the pediatric wrist fracture. Pretend I'm at home. This was a talk that was going to be given by Katie Yoon, who's ill, so I apologize about that. But it's not presented to give to you updates in science, but rather to decry that there is insufficient science to care for something that affects every orthopedic community. Indeed, one of the most common fractures that we all care for in one of the most important populations of patients that we care for. Indeed, the patient that's shown here was responsible for me getting criticized by some colleagues and actually going to our PPIC committee for inappropriately operating on this child by putting this metal plate in them. I'll get more into that later, but that stimulated me to do research, because obviously if you have to defend your position academically, you have to become a master of the literature, even more so than what you thought you were. I advanced the slide by pushing which button? Up or down? Got it. Or right or left. There you go. So we're going to, and all the X-rays that you see here are my patients, and all of them were wrapped up into this quote-unquote investigation of my management of pediatric fractures when they retrospectively looked at my pediatric care of the preceding 3 years. And so these are all cases pertinent to that review of my work. So we're going to talk about the incidents, the conventional thinking on the management of pediatric fractures, the current thinking, which is mostly still conventional thinking, the problem at hand, and the importance of achieving a consensus. Because what really mattered in my personal situation was the complete lack of consensus. The incidence of pediatric wrist fractures is high. It's the most common fracture in children, 36 fractures per 1,000 children per year, and it's most common in boys, mostly because of contact sports, but the incidence of girls, fractures in girls and boys is increasing over the past several decades. There's 2 million fractures per year in the United States, 500,000 in the United Kingdom, and almost 2.25 million in the European Union that are documented. So it's a huge, huge problem that may need to be formalized in research. The conventional thinking, the thinking that emanated out of my training, is that a distal radius fracture is adaptable. It is responsible, the growth plate in the distal radius is responsible for 75% of the growth of the forearm as opposed to the elbow region, and therefore any injury can be expected to be remodeled substantially. Predicated on this are the two factors that were considered mostly, and that is the amount of displacement initially, that makes sense, and the age until maturity because it's a function of growth correction. The greater the initial deformity is, the greater the amount of time can be, assuming they're relatively immature, the greater amount of time there is to fix that deformity. And it's been widely accepted that a full dorsal displacement in a child of less than 10 can be tolerated with only immobilization. And if you look carefully at the literature, most of the issues that are addressed are not why I took any of these children to the operating room. And that is that the literature is scant on documenting either before or after malrotation in the fracture. And that is 50% of what the wrist does for a living. The dependent variables in the current trends in determining what treatment we render is the age and maturity and the fracture displacement, as I just mentioned. However, the indications for closed reduction, pinning or open reduction internal fixation in the context of that remodeling scenario is open for debate. And the reason why we know it's open for debate is we have to look at the different trends that are actually being realized in the care of the pediatric wrist fracture throughout the world. If everybody just listened to the 1998 guidelines, we wouldn't be pinning almost any of them, let alone trying to reduce them. But that's not really what's happening out there. The confounding variables are the child's short-term functional needs. One of the children that I operated on, mother played first violin for the Philharmonic. Her daughter was an accomplished violinist, but she couldn't pronate to hold her bone. Should we have waited till she was 14 and remodeled her bone? Because the literature says two things. One, that she'll look great on the AP and the lateral projections, but also the literature says that rotation never corrects itself. And yet that's not monitored for. So the short-term needs of the child have to be considered. Parental perceptions and wishes, largely similar to above, have to be considered. Not all parents want their children to have a deformed arm for 2 or 3 years prior to it looking more normal. And it could be because of athletics, it could be because of child peer pressures, whatever, but parental perceptions are playing an important role, never showing up in the literature, but playing an important role in how we deal with all of our pediatric patients. Surgeon perceptions are changing, evidenced by the fact that there's multiple ways of treating these fractures that vary from the the pre-existing recommendations. And then there's the issue of risk acceptance. Surgery carries obviously greater risk. There's infection, there's hardware failure, but non-surgical treatment carries great risk as well. Literature is very clear on it, that even pinning a pediatric wrist fracture doesn't guarantee that you're not going to have increased rotation of that fracture over time. A substantial of distal radius fractures rotate while pinned, mostly because it's usually a single pin that's used, is my thinking. Again, there's no evidence on that because that's the topic of the talk. But the loss of reduction with mere pinning is substantial and generally considered to be acceptable in the AP and the lateral projections that are reviewed. There's also differences in how you're trained. General orthopedic surgeons are more likely to not reduce a fracture and leave it in place than a pediatric orthopedic surgeon. A general orthopedic surgeon is far less likely to open a fracture than a hand surgeon. And indeed, a hand surgeon is even 3 times more likely to open a fracture than a pediatric orthopedic surgeon. The country variables are significant. In the United Kingdom, almost always the 1998 guidelines are followed when you look at the published literature. That means you can accept a fracture that's a full centimeter of overlap if they're less than 8 years old, and rotation is not considered in the recommendations in the published studies. In the European Union, 83% reduce all kids, 77% under anesthesia, and over half get pinned, even if it's felt to be stable by pre-existing criteria. In the United States, 71% of those reviewed accept no overlap, in complete contradiction to the standards that we were trained under, and are still following conventional thinking. Sorry for the noisy slide here. The historic trends to review that angulation and overlap and rotation no less than an 8-year-old are more acceptable than greater than 8-year-olds because of the adaptability of the growth. Malrotation limit in the less than 9-year-old was accepted as high as 45 degrees. I think that's a crazy recommendation, and modern, more current literature has lowered that to 30 degrees. What's not investigated fully, but it's commented on in modern literature, is malangulation accentuates the effects of malrotation. So if you have a 30-degree malrotation, you're accepting that, and you're malangulated, the chances of that resulting in an acceptable outcome are far lower. And one of those variables needs to be eliminated. In my opinion, malrotation progresses without fixation, but even with pin fixation. What I think is the missing data is this, and this was the result of our collaborative investigation into the literature, is that there's no accurate way to measure malrotation pre or post-operatively. Now, I'm going to address some things in the next slide that you can do, but there's still no accurate way of doing it. And that's because of variabilities, not just in doing the studies, but interpreting them. 100% of the literature does not quantitate supination or pronation in defining an acceptable outcome. What the limits are, what they'll simply say is, and even in a paper recently in JBJS, says that the outcomes were acceptable without measuring significant changes in rotation. We all know as orthopedists that fractures with enhanced fracture risk, those that are obviously likely to go some instrumentation, increased obliquity, complete initial displacement, radius and ulnar fractures at the same level, and a suboptimal reduction. And with reduction, I would suggest that we always have to look at the distal radial ulnar joint, which is responsible for supination and pronation. This is a child that came to me, also a musician. Also, this one had the inability to supinate. It was treated at a teaching hospital down the street from me, and the family was told that this is an acceptable reduction. The child couldn't supinate. at all past 0 degrees, and they were told to wait till they remodeled. Wasn't acceptable to the parent, wasn't acceptable to me. So it's a Galeazzi variant. The overlap between the radius and the ulna is insufficient. There's the center of the ulna, there's the center of the radius. So my critique on this was I should have gotten bilateral CAT scans of the child's bilateral entire forearms, to which I would have exposed that child to more radiation than the equivalent of 100 chest x-rays, just to determine something that I can see on a lateral view of an x-ray, which correlated perfectly with their clinical examination. They couldn't supinate beyond 0 degrees, and the distal radial ulnar joint responsible for that supination was in fact not congruent. I don't need to spend a lot of money or expose a child to radiation to prove that. The other single article in the literature that talks about determining rotation intraoperatively is if you can pronate the child's arm 45 degrees, if there's a 5 millimeter step off, then you're malrotated significantly. Well, that's a tough X-ray to get in a malrotated fracture in a kid, even under anesthesia, and it doesn't determine what age. I mean, a 5 millimeter step off in a 6-year-old is much more substantial than a 5 millimeter step off in an 11-year-old. So, so the criteria for determining step off and malrotation still aren't solid. And what is 45 degree pronation? Is it the forearm? Is it the distal radius? Is it the fragment, which you don't know how malrotated it is to begin with? So neither short nor long-term compromise has been accurately assessed in the pediatric population. This is increasing as the leading cause for closed and open instrumentation, in my opinion, because the trends are to close and openly instrument. This is that child there, if I put a plate on, and which also went under review. So their approach to this was for me to ask my department, well, show me the clinical practice guideline that dictates that I violated the standard of care, of which no academy has developed one for pediatrics. The first step in developing a clinical practice guideline is to get a consensus. Sorry for the noisy slide again, but I'll narrow it down. Consensus is hiding way down here at the bottom. That's just not just a collection of expert opinions, but it's a collection of expert opinions that agree with each other. I got a collection of expert opinions. I got 30 expert opinions, 25 of which were people that I never met or heard of. I solicited their opinion on it. And that was fairly easy to do. Somebody that Dr. Rao actually gave me an opinion. But an expert opinion is still only level 5 evidence. It's relatively worthless in the development of a clinical practice guideline. What you need for a clinical practice guideline is strong evidence. You need several high-strength studies that constitute level 1 or 2 evidence. They just simply don't exist in the pediatric population. So in summary, there is no consensus, and therefore we can't develop a clinical practice guideline. It's impossible to do. No consensus is a function of the lack of meaningful evidence. We're not measuring everything that matters. We need level 2 or 1 evidence to determine appropriate care and to develop these guidelines. And that means we need multi-center perspective data to assimilate in random controlled trials, et cetera, which should be something that's very easy to do with the density of pediatric fractures that we have in our country, let alone a combined multinational study, which can give us 4.5 million fractures per year. Most of the initial conventional thinking guidelines were established in the mid to late 90s that I referenced earlier. In a teaching textbook of Rockwood and by Rockwood, and there's a summary of pediatric fractures in 1998, so it was conventional thinking back then, or at least it was known back then. And in the summary of the chapter on pediatric fractures, Watkins makes a statement that the only way to achieve a successful outcome in a pediatric fracture is to ensure that they can pronate and supinate afterwards. Since that time, we have not ensured that. And thanks for listening.
Before you step down, Mark, so, I'm a neurosurgeon. I don't do this, and nor do I completely understand it, but I do understand development guidelines. And one of the statements you made a couple of times is you're trying to measure pronation, supination, and it's, quote, never been done, nobody's done it. We have found smartphone applications to be incredibly useful for a lot of different things. So we measure our outcome scores now in walking, patients' ambulatory ability. We frequently will do with the smartphone applications uploaded. We'll access the patient's smartphones. I would imagine a smartphone on somebody's wrist could measure pronation and supination, or I could imagine that technology wouldn't be too difficult to gather. And I'm saying this to encourage others in the room. Lucy's going to talk about robotics, but just to encourage others in the room to.
I think that's a good point. I mean, there's lots of ways of assessing data. So right during this in-house investigation of my pediatric care, my partner, who's my age, comes to me and says, look, I have a pediatric fracture and he's doing fine. And he goes, he can supinate just fine.
I see.
Right?
Yeah.
So, in reality, I invited him to bring the child in, right? Because if this is how they supinate, it's not supination, right? We would be remiss in being honest in that we treat different populations differently. If we have, if I'm taking care of a peripubescent Olympic athlete, a gymnast, am I really going to ignore their ability to supinate and pronate? No. We do meniscus repairs and spine surgery on children that are rotated, but not necessarily dysfunctional. There's malrotation systems we address orthopedically all the time. The critique here is we all recognize that malrotation is an issue. We're just not measuring what matters. When you look at their literature, they're commenting on the remodeling of the X-ray, and they're only showing AP and lateral views, which will remodel perfectly. But nobody's commenting on the supination and pronation. And I've seen several patients, mostly overseas, but I've operated on many dozens of kids who couldn't supinate or pronate because of an incongruent distal radial ulnar joint, which otherwise would have been found acceptable remodeling on their AP or lateral projections. So the call is for, we have the density of fractures, we should just organize ourselves to a point where we can actually treat them and not just sweep that population under the rug.
Please don't sit down yet. Any other comments or questions? If not, I have one more. I'm not saying do it, don't do it, etc. I'm just saying scientifically, how do you measure the movement? And I mean, there's a lot of 3D modeling now, the whole CGI from the movies where you just put trackers on the patients. So, I mean, the point you made is excellent. We see that even in ambulation, but you could actually monitor the movement with tracking devices, which are cheap now, becoming readily available.
Right, you could do it. You could do it digitally, but we can resort to what we've always done and have the patient just stick their thumb straight up in the air while the elbow's in neutral and see if they can actually supinate or pronate, right? It's not a mystery if the child, if you lock the elbow and the child is supinating like this and they're pronating like this, then something's wrong, right? Do we really accept 45 and 45 degrees, right? Well, they'll never get better than that, right? Will they be that competitive athlete when they get to high school, right? But maybe in cross country, but maybe not in football, maybe not in basketball. Try to shoot a basketball without full pronation, right? Are we not being fair to that population? We're not measuring what matters.
Who's gonna be next?
You want, are you gonna go? You want to do yours? Okay, go ahead. We'll do Dr. Zamorano's talk, use of robotics and neurosurgery. We're trying to accommodate speakers so and the speaker schedule, so our sequence is going to be roving a little bit today. Our next speaker will be Dr. Lucia Zamorano, who everybody knows, who's going to talk about the use of robotics in neurosurgery and give us an update. I don't think it's working.
Hello. It's not working.
It should be working.
Hello.
There you go. It's
It's working?
Yeah. Did you press the button on top?
I did.
I can hear him. Can you hear him?
Can you hear me well?
Where are the speakers?
It's not on mute. It's not on mute. It should be working.
Okay. Is it way to increase the volume?
I can do it from here and I've got it all the way to the top.
Okay. Okay, so you can hear me?
Yes.
Okay, good. So, so I will start with this presentation. It's a little bit of a historical presentation, almost in robotics in brain surgery. As nowadays we have different other alternatives for also spine, but I will focus this on the robotics in brain neurosurgery. How's it?
The side button,
The right, left,
right button.
or up and down.
Which website? Oh, there's a few segments here. I'm moving there now. Deja. Yeah, sure. Yes. We can do this. I guess this can be a okay, so this is the presentation. We come here at William Bowman of the University. And a lot of this work was done prior in another university at Penn State. It's really difficult to. So let's talk about what is the modern robot. So a robot is this is the definition according the Robotic Industry Association. It's a programmable, multifunctional manipulator designed to move materials, part tools, or specialized devices, like in our case, for performing some type of surgery. The advantage, obviously, is that it improves accuracy of procedures, allow finer control, and increase the reproducibility or consistency of procedures, what actually is something that in surgery becomes very important. Results, we see in the literature, results may vary between different doctors or different groups. So in this case, with robots, one of the ideas would be also to increase the reproducibility of the results. what would be an advantage for patients. Another advantage is remote activation, longer endurance, they will not get tired, improved safety, and minimize the duration of procedure, and they can be more targeted to the specific problem, and provide a new possibility for minimization of the surgical task. The history of robotics in brain surgery, at least from this, in the literature, in 1985, Paul performed the first robot-assisted CT-guided brain biopsy with Puma, with this industrial robot, and this was the first procedure done. In France, in Grenoble, Professor Ali Benabid developed what was the original Neuromate with this robot. In 2000, the 2000 Neuromate was the first neurosurgical robot certified by the US FDA. And I mean certified, that's exactly the term. At Wayne State University at the time, in my lab, we did this work that supported the certification by the US FDA. And this was also published. And in the year 2000, also we performed the first CT-guided biopsy, so the first in theory, first robotic brain surgery with this system in the United States. And now this Neuromate that we will see very soon is still in use in the world and in the United States. The original company is under the term Renishaw now, that is located in, they have headquarters in all the world, but the main is in United Kingdom. So what are the critical applications of robotics in brain surgery? Well, very important for functional neurosurgery, and this, especially in epilepsy, has been lately the deep electrodes that were used and abandoned sometime in the past, they have been in the renaissance again due to with the use of these robots. Because you can basically place multiple deep electrodes for somatosensory for deep electrodes placement, and then locate exactly the epileptic seizure and perform the surgery. And also for the deep brain stimulation, this also involves usually one target. So this many people do with robots or without robots. But this stereotactic electrodes grid that we call for epilepsy, definitely the robotics has changed enormously the current use of this type. Biopsy obviously can be done with robot-assisted resection of intracranial lesions, and this is usually done with some laser guidance managed by the robot. Radio frequency thermopoulation, laser interstitial technotherapy. This has been quite important lately for epilepsy as well as for tumors. You can couple endoscopes to the robot. And for drug delivery convention exams, enhanced drug delivery, and it also has been done with using these robots. We have this role of radio surgery, robots in radio surgery, and laser osteotomy, some newer applications. So this is the Neuromate that I mentioned. That was at the time that we did the study was company that was involved in integrated surgical system from Davis, California, and this was because we sold to this company Renishaw, and that is what is currently how you can purchase this unit nowadays in the world. So the Neuromate is a 5-degree freedom robot and allows to frame and frameless approaches. Here is an example of using the robot to basically, the way that this was approved, to aim the target and basically you can place in this case a biopsy, and the needle biopsy that need to be pushed by the hand of the surgeon. That's the way that the FDA has approved these devices. So obviously for trajectory becomes anything that is a single trajectory robots is basically the ideal tool to use. There is a lot of involvement of preparation, obviously, registration. This has changed a little bit over the time to make it more easy on the patient. The registration, at this time we had a fixed device that attached to the patient, and nowadays can be done a little different too. And these are the process that you can see that with a biopsy or with any resection, you can in multiple ways you can target multiple points that can be important in the specific problem. This was something that in the future we have seen more, and this is one of the areas where robotics can have a future tremendous impact, is the addition of other type of technologies, like for example augmented reality. This was something that has been continued improved. And you can see here, for example, in the case that we were following, that you can have a real-time augmented reality visualization of tumor, in this case, of the vessels, without having to do the large craniotomy. So this specific, can be extremely important. And this was a little bit experience that was used at the time for when we did this this article and the type of procedures. As you can see, different from implants to biopsies to craniotomy for tumor resection or epileptic foci. The results at the time we were able to report it that it was no complications and very accurate type of the intraoperative registration, and all the type of tools that you can use, catheter, electrodes, or anything that is a straight linear trajectory. Obviously, this has excellent alternatives. Accurate position of craniotomy and some guidance during this surgery can also be obtained, and we double the time that has been done following many systems. A laser beam as a pointer, so you can have some interaction with the laser beam coupled to the robot arm, can show you different points that can be, or areas that can be of significance during the surgery. And the augmented reality idea that can improve the intraoperative guidance. And obviously with all these, you have some of these proposals at this moment. One of the major problems, like in any of these other procedures, is the fact of changes that occur in the craniotomy and how to update those changes. So that was the objective of some other research in intraoperative imaging, like it's intraoperative MRI that can be very cumbersome, or can be other models using some other like machine learning type of technique for modeling and predicting these changes on the brain as they occur during the resection. Those techniques are still being developed and hasn't been completely developed, as we said, but certainly the research has been expanded enormously. And now, basically, we have with artificial intelligence, we have as you all know, it's been improving. So this can give probably some new guidance to this type of procedures. This is another concept of the let's have the robotic operating microscope, where really this is the system NKM. I don't know how many of you had the chance to use this. At the time, I mean, I really love this system in a way. It was a tool in navigation and guidance, and you will have through the projection of the microscope. So in a way, I'm surprised that there hasn't been so much further development of this kind of approach at this point. But it was the same concept, the image registration, and you will find the target and other volume of interest. And you will get your knowing the focal distance and the autofocus of using at the maximal magnification. That was basically your reference, and that's how this image space registration will occur. So you will have, you will have this NKM, and you could use also some other, adding some infrared tracking technique that this has been added to many systems nowadays. You could have something more also dynamic and outside the view of the microscope. As a help also for tracking. But this was the concept. Like here we have in this case, you see this lesion. This is a cavernous angioma, deep and depth, but you can, when you are in the surface, you see the projection of the empty area that you have planned based on all the anatomical, the implementation of motor cortex or mapping, whatever has been the data acquisition. And then you can see how in this case was a lesion that you can, this is the contour of the lesion from the surgeon perspective and your trajectory, and you see how they can touch really nicely in this specific case with a relatively well-defined lesion. So this was an extremely useful tool for true navigation and where you can display the contours from a surgeon perspective. And it was showing, these are some cases that have been published. The section of the tumor, for example, and then using this type of technique. So now this system for brain neurosurgery, so we talk about the NeuroMate very short, and there has been other system that you probably are familiar to, the ROSA system that is from Siebert, the Surgiscope, the Renaissance system, the based on robotics, based on as a system mostly for the spine, but then evolved also for brain. Then you have the neuroarm robotic system, the ICS developed in Minnesota. And at this moment there is also the development of small footprint systems like AutoGuide, it was known as ICS-1, and the Brain Lab here. These are small devices that instead of having these large robots, these are small micro footprint systems that can be maybe in the future easier and less cumbersome to use. We have a small system. Robotics with the brain also has been very important in brain surgery. The gamma knife that we have been using for so many years in different type of units. People don't think that really has been robotics part was have done a lot of improvement. The U unit, the loading to the V unit, when the loading of cobalt sources was done using a robotic arm, and that was a very important change. It was just the change of the cobalt sources. With the unit C, we include a robotic positioning system, the APS, that basically has a robotic retrofit. The perfection unit, which is the next one, used a robotic pump, and basically there the bed became the robot of the system. And finally, the one that we have used now, the gamma knife icon, added a cold beam CT to the technology, and in that way allows the mass visualization for hypofractionated surgery, so frameless. And the LINAC, we all know, is the role of robotics in LINAC-based systems. You have the couch positioning for the automatic couch positioning, the multi-leaf collimation, and one of the typical where the robotics becomes the holder of the LINAC is the cyber knife. Here is a picture of that. So basically, it's the LINAC accelerator is being managed by the robotic arm. So future, I think there is a enormous future in the robotics applications in neurosurgery from the point of view of the planning, using multimodality imaging and functional imaging, physiological imaging, molecular targeting imaging with genomic information. So all this, whatever implies a very precise target, robotics certainly can become an instrument of a very important tool. Machine learning techniques to optimize the surgical and reduce surgical planning. And this goes also with coupled with the artificial intelligence, where you can have also add data of outcomes to this planning. We have the fact of more advanced visualization and display techniques, as is what I show the reality. We can have more computer control tasks and non-linear movements. This is something that is being developed slowly. It's difficult, robot-assisted craniotomy and dissection. And basically also integration of robotic with other tracking systems like infrared, sonic, and magnetic fiber optic system, depending on the application. And more important, my time, more important is to optimize the surgeon robots, the computer interface, so with the robotic platform that incorporate the software platform. So all these are ideas that can be in the future for the planning phase. Intraoperative, although we have discussed artificial intelligence, mathematical models also to update the information, haptic perception, the miniaturization of robotics, the surgical robot that can be something interesting for the future when we have faster communication. And you can see that we were talking about performing surgery, managing from one side and having the actual robot in another side. These are covering research on this area, but hasn't been done yet as actual surgeries. And basically, that will go to the levels of autonomy, and that's obviously the big question: how much autonomy we want to give to a robot. And futures of robotics in neurosurgery beyond the operating room, the presence of robots, obviously in neurosurgery training, and the use of robots for rehabilitation and assistance. This is something that is a very important development at this moment, and there is a lot of research in that area. So this is a little overview of what robots, where we are, where we were, how pathway, and what is the future of this technique incorporation of robotics in neurosurgery. Thank you.
Let's see if we're going to get questions. Let's tee up Dr. Ramafula's talk. Is Dr. Ramafula here? Yeah, great. We'll tee up your talk next, please. That was what we had presented as the original talk. Questions? I have some questions. It's one might expect.
I was curious what your thoughts are. In Washington right now, there's a lot of debate about artificial intelligence and how it needs to be regulated. And a lot of companies like Amazon and Google are laying off labor force as a result of how artificial intelligence is going to affect their labor pool. How do you think the eventual integration of AI into the surgical subspecialties, and since you're so facile at robotics, is going to affect the labor pool for surgeons in the future?
Well, that's a complex question. I think that artificial intelligence definitely has a tremendous role for medicine and the potential. There is some specialties, I would say, where you can envision a tremendous role and may change the way that some specialties run. For example, radiology. If you think about if artificial intelligence, where you incorporate all the anatomical data, all the data of pathologies, of findings, specific findings in imaging. It's probably one of the areas where you can think that using artificial intelligence can give probably even a better diagnostic and more reliable diagnostic than using human. Now, all these techniques should always have some human overseas of the technology. So there are some areas where I think that it may impact. I mean, maybe radiology will be, I don't know what my colleagues radiologists would think, but maybe it means that they will have to change a little bit how maybe the role of radiology will be different using these techniques. In other areas, like in surgery, I mean, it also becomes an issue. Obviously, robots are expensive, very expensive, but if you incorporate artificial intelligence with robotics, maybe we will get more precise surgery, more reliable, more predictable outcomes. And so it's a fascinating time, but it's also, there is also the dangers of some portion. Now, the other dangers for artificial intelligence is beyond, that if it gets in the bad hands, there's a lot that it can do what it does. We've seen a lot of this information now after 3-4 minutes of use talking, artificial intelligence is capable of simulate you talking or saying something that you never thought, and it becomes dangerous. So definitely they need to be regulated, but I believe that it can be a tremendous impact and a good impact for medicine managed in the right way.
Just one question, Jeff.
A few years ago, Billy, you gave a talk using the Da Vinci for an L5-S1 A-lip. You said it was your first case. Was it your last case?
I did 16 in total.
So you're still doing it?
No.
But I was going to ask whether Lucia had actually done anything with the Da Vinci robot.
Actually, it's very interesting because when we were doing this research, what people don't know, that the original research of the Da Vinci robot, the original was really for brain. But the people that, so I was involved a little in the original research before it was even out to the public. And that was the original idea of the Da Vinci robot, to work on the brain. But the people, investors and other people, they realized that the market for brain was very difficult, and also with the problem of the, that you don't have the space to mobilize the robot, then very early they started moving more into the abdomen and areas where you could have air, and movement wasn't such a critical factor. I've never used the Da Vinci robot myself for immediate approaches, but I know people have done it. I don't know, it's probably a lot of work for us.
As the residents say, a long run for a very short slide. That's the way they describe it. So thank you very much.
Want to close that one out? You want me to close that one out?
Yes.
No? No?
I think the room is small.
Okay, I won't worry about it
We're just getting on.
Okay, thank you. this one, okay.
While we're getting this time going, let me ask you one other question. I've been doing robotic type things since the 90s. So the junior faculty, we have all these great robotic systems now for the placement of instrumentation. So my junior faculty has expressed zero interest in robotics, and you know I'm still excited about robotics and think there are broad applications to it. They've proven effective, they've proven accurate, there's a huge amount of literature behind them. You know, money notwithstanding, I'm just curious to see that the junior faculty had no interest, at least in spinal robotics or frankly, cranial robotics. So I'm really asking you, why hasn't this been a bigger market? We have, you know, 8 microscopes, or hospitals have 500 to $1 million microscopes, but won't have much in the way of robotics. Are you ready, sir? Okay.
That's, I mean, it's a good question, and, I mean, there are people that, some of the junior faculty that may become interested in this field, but certainly, usually robotics at the beginning doesn't help to get your procedure faster. I mean, it's usually the opposite. It's you spend a lot of time to get something going, but once it's already optimized, that is where it helps. And one area, for example, that we do see a lot of impact at this moment, I would say, in functional neurosurgery, especially in epilepsy, and the use of robots has changed the way that this moment, I think, in general, because of the deep electrodes and also for the in the case of the deep brain stimulation. Those two factors, those two problems, I think, is one where we see more of the impact of robotics at this moment. But for the resective surgery and biopsy, it certainly is a lot of work to get something that we think that we can do without the use of robots. But I think the future of the capital of these techniques and also the increasing the cost of these robots may change the way we do things at this point. So hopefully the younger faculty get interested in all this type of, and certainly the important change, I mean, that was the reason of my topic, but in spine, definitely there is more impact of robots at this moment for placement of instrumentation.
I think also the robots have changed or evolved with the new Mazer robot and Globus. You know, they are more streamlined, they are more efficient with the workflow. So people are sort of getting more inclined towards it as a tool in spine surgery. So I think, you know, more yet to come. And for cranial stuff, like for tumors, laser thermotherapy, they use, you know, it's all robotic guided intra MRI at the centers that are doing it. So I think Comedy and Cleveland Clinic and other locations around the country for both epilepsy and tumors, it's all a robotic guided procedure in the intra MRI, and you're sitting at a console. So it's just, I think it's evolution, cost, efficiency, and volume, you know, all together in a private practice. I don't know if you could take the time with the robot to learn it about 6 months or 9 months to get that workflow for your staff and everything else. So, you know, I don't know how it works. Those are some of the factors which make it difficult to just jump onto a robot and say, you know, I'm going to do it, when you can do something quicker on your own and you already been trained to do it. So.
And the next speaker, by the way, will be Dr. Robotics. Dr. Robotics will have the next. Thank you. Go ahead.
Good morning, everybody. I would like to thank the organizers for the opportunity to present some of my work. It was on short notice, so I recently moved as well from the University of Florida to Mayo Health System in Eau Claire, Wisconsin. So I was able to, you know, get the medical students and postdocs to come up with some of the slides and the data. It's a work in progress and going on. But basically my goal with this talk is sort of a case-based presentation. When I go through some of the CV junction fractures, we commonly see them more frequently in our trauma centers. They were increasing in frequency down in Jacksonville, and I've seen here in Eau Claire as well. And I'm going to just briefly touch upon my experience and some of the numbers that we have, the numbers that I had at the university. So we all know that as our population is aging, we are seeing more of these fractures, especially C2 fractures, fractures of the dens or rhontoid. And these are fractures that we see with low velocity impact. An elderly patient falling from standing or falling from a chair and then coming to the emergency room with mild neck pain, and then you identify a C2 fracture, or your ER doc identifies a C2 fracture. We do see more significant fractures as well, occipital condyle fractures, dissociations, C1 fractures. So it just depends on the type of injury, the impact, and other factors. But commonly, C2 fractures have become more frequent in our ERs. So when we talk about these fractures, there are always two methods with which we think of treating patients, depending on their comorbidities. We always look at non-operative interventions and then operative interventions if they are unstable or are neurologically compromised. We see that the type 2 dense fracture, is common and has a pseudoarthrosis rate of more than 50%, and these fractures are associated with high mortality at 3 months and at 2 years down the line. We always have classification systems. It helps us communicate, and over time there has been an evolution in the classification systems as well. My preference has moved on to the AO spine classification systems. They are more standardized, easy to communicate, and I guess when we pull up data and record data and try to present or get information, it's easier for everybody to sort of use this fracture classification. Of course, we have Vaccaro's classification of stick and helix for the subaxial spine, the thoracic spine, but I've just found that the AO is comprehensive and covers almost everything when we look at injuries. So just a brief slide just goes through different fractures of the condyle, the craniocervical junction, the C1 ring, and C2, C3. They have neurological modifiers which help surgeons decide on whether we want to take them up, whether they're unstable or have neurological compromise to be taken up for surgery. And then we've got case-specific modifiers depending on the comorbidities that a patient may have or come in with. In this talk, I'll specifically look at the C2 fractures. Anderson and Leonardo classified them into 3 types, which we all know. Type 2s are the ones which heal poorly and present with problems down the line. Type 1s usually don't require any surgical treatment, and type 3 fractures, which go through the body of the odontoid or the dens, heal well. I wish there was one way. My kids nowadays, they tell me, Dad, this is the way. I'm like, they love this show, The Mandalorian at Disney. And I wish I could tell you this is the way with spine fractures around the CV junction and C2, just jump in and operate on all of them. But unfortunately, there is no specific one way in treating our patients. We see that they have different comorbidities. So we have to sort of individualize patient care based on our experience, the type of patient, the comorbidities. And there are various treatment options. We've got the cervical orthosis, or the hard cervical brace. An extension of that is the cervicothoracic orthosis, which provides more stability. Then we've got, of course, the Halo West immobilizer, which is a bit cumbersome to place for elderly patients, difficult to also manage with. And we've got then the surgical interventions, different types of fusions, C1-2 fusions, odontoid screws in selected cases, and then occipito and atlantoaxial fusions in others, depending on the type of injury. So initially, when I joined the university, my partners used to place a lot of these patients in the Halo West because we felt that it had a safer risk profile and that we could get them out without the morbidity or the complications with surgery or surgical intervention. So we published our initial series of 4 years in patients with a Halo West, we had about 60 patients, and they did pretty well, but the difficulties were continuing to follow them up diligently, making them come in every 6 weeks to get imaging, and then their ability to tolerate the halo vest. It's not a very easy device to wear and then continue your activities on a day-to-day basis. So it is a safe and effective treatment, especially when we think that surgery may be of higher risk and associated with morbidity and mortality. And we found that in our subset of patients, the commonest complication was pneumonia and pin site infections because of the difficulty for patients to breathe, depending on their body morphology. And then the long duration of use caused issues with activity and conversion to surgery, finally, if the halo vest immobilizer failed.
Doctor, were those a pre-selected group of patients?
They were a pre-selected group of
So
patients.
they're probably pretty old and medically infirm.
Correct.
And despite that, it looks like they still did pretty well.
They did after they came out, and when they came in, the ISS scores were pretty high, and they were conducted, may have been poor GCS, and so it took a while for them to come out. So we didn't know whether to jump in with a surgical decision. Sometimes families take time to decide as well. So the halo vest was a good, it's a good intermediary method of managing these complex patients, and a majority of them they do well. I didn't present the numbers on the slide, but the paper is available in the British Journal of Neurosurgery, and I can email it out if anybody would like that. So, going on to one of the patients I initially managed conservatively with the halo vest. It's case-based, so please free to chime in whenever you all feel like. At the end, I'll just talk about the brief results that we've got. So this was a 78-year-old female patient, December 2015. She had C1, C2 fracture with interval worsening while we followed her up, and a lot of comorbidities: hypertension, morbid obesity, sleep apnea, osteoporosis, and asthma. And in her particular situation, I think she had a high ASA grading as well. So the anesthesiologist was not really excited about putting her under anesthesia, turning her prone, and helping us out with any surgery. So this was a patient whom we decided to place in a halo vest immobilizer. The slide is really not that great because it doesn't show the fractures, but she had an anterior arch ring fracture. The orantoid was displaced. She had a crack through the orantoid as well, and she had a posterior fracture through the posterior arch, along with some ligamentous instability on the MRI. So this is another slide showing the C1 fracture more clearly, but the C2 fracture is not clearly defined. It was more comminuted, and over time got displaced.
Do you give them bone growth stimulators?
I do, actually. It is in my preference wherever they can get it, because it's sometimes difficult for insurance to approve it, not having any data out there, and expert opinion level 5 is difficult to convince an insurance company sometimes, especially for these patients in Medicare. But Medicare does approve it in many states and locations. At least in Wisconsin, they're pretty good with approving it. Florida, I had a tough time. But this is the fracture, or the initial fracture that she had. It took 9 months, and this was the final image. Okay, and that's a pretty long time for a 78-year-old patient. But she was active, she was doing everything. Her husband took good care of her. So, to answer your question, here we have this bone growth stimulator on her. When I took out the halo vest, we changed her up to a cervical column because we didn't know whether she was fusing out at 4 months. And the scans that I showed you in the previous slide, this is 6 or 7 months out of being in the immobilizer. So it's a pretty long time. And she got a bone growth stimulator, which she wore diligently. Her husband was very caring and took good care of her as well. So the pros of this method are it avoids a major surgical procedure. The procedure involves sometimes blood loss, nerve injury, comorbidities, recovery. The patients are sick when they come to the trauma center. So a lot of other factors can be avoided. You go in conservative. The cons are the long duration of follow-up. Sometimes you're concerned. Have they fused? Have they not? We don't see bridging bone. So we look at fusion by fibrous union, or non-union of bone but fibrous union of soft tissue. So we keep them in their brace for a long period of time. That means they have to continue following up with imaging for over 6 months, and they need to come over to your clinic to get seen. So it's cumbersome for them. Patients need to be active at self-surveillance. Some patients just decide to take off the collar after removing the halo vest, or they cannot tolerate the vest and get it removed at another local ER. They have to be diligent at utilization of both the breast, the halo vest, the cervical orthosis, as well as the bone growth stimulator if they are able to get it. And if it fails, finally, they require surgery. The second case is more surgical, okay, and as I discuss a few of these images, I'll go through some of the techniques that I use for operating on these patients. The series is interesting because I use navigation guidance only for all my cases. I don't use fluoroscopy. I've moved away from it. So all the 40 or 45 patients that I present at the end are navigation based or navigation guided patients. The reason for that is that a number of these patients come with vertebral artery injuries as well, significant dissections. Before, we used to scan them infrequently, but now our trauma surgeons get scans for them pretty frequently. So we find, grade 2, grade 3 dissections, or we find occlusions, and then we have to be careful about preserving the contralateral or the vertebral artery, which is intact. And so, and some of the injuries are complex, so navigation has helped me insert the screws. Fluoroscopy is, also very good because anatomy and the CV junction presents itself. So navigation is just a tool which is supportive or an adjunct. When I was training, they'd say a fool with a tool is still a fool, no matter what it is, or a monkey with a tool doesn't help them. So we have to use this, understanding that our knowledge of anatomy and the location of structures, fluoroscopy, intraop imaging is all important, and navigation is just one more tool in the process. So another 75-year-old gentleman fell around August. He had an anterior arch C1 fracture with a type 2 dense fracture, and everything looked aligned. So we decided to manage him conservatively. Followed up a month later, there was no healing and worsening displacement. He got operated about 2 months later because he started developing neurological issues as well. And his comorbidities were arthritis, asthma. He had a prior stroke with a cerebral artery occlusion, diabetes, hypertension, and thyroid disease. As we grow older too, we sort of accumulate a fund of all our comorbidities. It just keeps coming on, no matter what we do. So this is not uncommon at all in patients who are in their 70s or older than that. So it's like a bank where the interest keeps coming and you can't do anything about it. So this is a scan, okay, and the image on your left is the initial study, where the C2 fracture was aligned. There wasn't much displacement on his initial scan. But when he came about 6 weeks later, you can see that his head, the C1 as well as the condyles seem to be retroflexing his orontoid. And now he's got compression on the core. And he started developing myelopathic symptoms, difficulty with gait, very subtle, but he felt the change. And he was quite an active gentleman. These are further sequences of the same image. This is A. When he initially came, you can see the orontoid fractures aligned. He's got a fracture bilateral, the posterior arches, and maybe an anterior ring fracture. Yes, he does have one, which is more clearly seen over here. This is the scan done 6 weeks later, where we clearly see worsening displacement, a widened orontoid, and widening of the C1 arch as well as the posterior arch as well. So it's an unstable injury, pretty significant, not improving with 6 weeks of conservative management. And this is his MR imaging. Again, when he came, you can see no cord compression, the orontoid is well aligned. So we were hoping that he would heal, but these fractures don't heal that easily. And this is at 6 weeks again, where you can see that the retroversion of the orontoid and the weight of his head and muscular condyles sort of started causing early compression of this cord. So this image was taken, early on in the series. At that time, I wasn't using a Jackson or an Allen Jackson table for my cases. I moved on now, and I use the Jackson Allen frame for almost every possible case. The reason for that, it's more aligned with the use of the OARM or the CT guided system. and you can get it easily without any obstructions. This table sometimes has a lot of metal bars and comes with a lot of artifacts. So the Jackson table or the Allen Jackson table is ideal. For navigation, this is my setup. The patient is prone. To the Mayfield clamp, I attach the navigation frame, just like we would for a stereotactic biopsy.
Just a question, did you have a preset algorithm as to how you go to surgically treat these patients specifically? Why not an anterior, I would, but maybe why not an anterior screw with that patient?
So his morphology was not ideal, his chest, the angle, the trajectory. So, and he had a C1 fracture which was getting displaced. I didn't really feel that this was, just an ideal case for an orthopaedic screw. There are cases where, just a C2 fracture isolated would be great, especially if the morphology and the sternal structure allowed for that trajectory. But in this case, just felt that the posterior fusion was ideal.
Thank you.
So, just like the cranial setup, we've got the navigation fixed to the Mayfield head frame. The patient is prone. This situation he was on bolsters or gel rolls. Now it's just with the Jackson frame once again. And before we turn the patient prone, we have neuromonitoring come in. We do baseline motor and sensory low potentials. The anesthesiologist optimizes our patients, and then, with multiple people on either side, we turn the patient prone. Sometimes if you're concerned about displacement or getting the fracture aligned, I would recommend putting the patient in a halo vest, and then you can turn the patient in the vest and connect the vest frame to the Jackson table. They have an adapter or a connector, and that would stop any movement if you're concerned about a very unstable patient or an occipitomantle dissociation. So that would be one of my recommendations. But otherwise, a majority of them, with a good number of people on either side, support, you holding the head, can safely turn these patients. When I feel, yes?
You can actually do the surgery in the halo vest. You just remove the back part of the vest and the two rods in the back. That's I think a very safe and very effective way to do the surgery right away.
Correct, and I agree. I have done some of them that way. And so it just sometimes varies. So sometimes they do have the halo on and it's easier. Sometimes it's not on and we take them. I also move towards doing surgery for these patients somewhat earlier rather than waiting on them as my practice evolved. So we don't wait to put halos on. We can take them directly for surgery as time went on. But the halo is a very safe and effective way to immobilize a patient and get them prone and operate on the patient. So once the baselines are obtained, the patient is flipped, and then we get another pair of motor and sensory work potentials. And if they are stable, the anesthesiologist can go ahead and sedate or paralyze the patient deeply, because we don't do motor evoked potentials continually. If you continue to monitor them during your dissection, you see that there's a lot of muscle twitching and spasms, especially when you get down to C2, and patients tend to extend their neck. And for whatever reason, Mayfield, there is a very small degree of movement that happens. I mean, you all would have noticed it. You don't think it's much, but the patient just twitches and extends his neck, and that moves things. Not of importance if you're using fluoroscopy, but when you're using navigation, you don't want that to change. So the patient is paralyzed with the dissection to the anatomical structures. And once the structures are exposed, I use sort of the navigation reference frame and insert the screws, as needed to the appropriate lengths. In this patient, I did an occipitocervical fusion, because of the extent of injury and the displacement of his head and C1 was significant. So the question is, how do you support that with a focal C1, C2 fusion? It never have worked. So he required more support at his occiput, and that's why I decided to go up to the occiput and place a plate over there. I spoke to the patient. Elderly patients, this is not ideal because they won't be able to move their head and neck. They have no flexion, no extension, no rotation, so it's very limiting. But you want to still preserve neurological function and not have them get quadriplegic. So this is the construct that I use. A semicircular occipital condyle plate, and then two rods connecting into the plate. I use in a bunch of cases the Sontag wire to hold my bone graft down over there. And in this case, I used rib allograft, not autograft, but allograft. And some patients I've used iliac crest, autograft, and I've sort of varied it out depending on the morphology of the patient again. Sometimes it's easy to get that iliac crest bone, sometimes it's a struggle, so you just have to decide what you feel is the best. In some patients, you may not want to use bone graft between C1 and C2, so I've seen that, bone chips and whatever bone graft material that you use to have an infusion, whether it's stem cells, non-stem cell product, osteocells, osteoblasts, any of them seem to work with pretty much the same efficiency. So I think it's your preference and what you feel is the best in that situation. This is just a slide showing how I use the reference arc to identify anatomical landmarks. One of the points during dissection of the CV junction is when we dissect C1 and C2, or the space between them, we get a lot of venous oozing, a lot of bleeding, and sometimes you're concerned about how this is going to stop, or is it arterial or venous? It looks bright red, so a majority of it is venous blood. So the only way to stop that is using Surgiflow or Flow-Seal or whatever your hemostatic material is. Gently inserting it, compression with the bucknoid, and time, gentle pressure, gel foam, whatever you use will bring about hemostasis. So that is something that concerns us as surgeons, but we can always get control of it at the C1, C2 level. And because of the dense venous plexus around the nerve roots, it's bound to happen. There's no way you can avoid it. So that's one of the things.
It's interesting to see where your receptors are. Where's your pickup for your navigation equipment in this scene? Because you frequently, especially at C1 too, you run into problems where you can't quite get the balls to register with the array.
Got it. So my reference arc is off the side, and the navigation is in front. Near the anesthesiologist, that's where I sort of.
You have no problems with that, so.
Usually no. We can adjust the frame appropriately to match up to this, and we sort of do a pre-initial check with everybody in the room before we sort of set things up, because most of the instrumentation is registered, prior to us, prior to everything, so we have a good idea.
Your reference is connected to the Mayfield.
To the Mayfield, correct.
And do you get any variation, do you think, as you go a little bit lower, C3, C4?
I haven't seen much of a variation. I used to connect it to C2 when I used to do C1, C2 screws.
Yes.
I found more of a variation in that when I insert screws and things move around, and that's why I moved over to this method of doing it. They also have an adapter which connects your reference frame to the Jackson table, so you could do it either that way or you could connect it to the Mayfield frame. Sometimes it's difficult because the patient's nose may come in the way where the frame locks in, so it's a choice, and the navigation folks have a whole bunch of tools that they can help you out with. So.
I find it more easier to connect it to the Jackson table because assist when he's assisting, if he puts pressure on the head, and then the Mayfield twists a little bit, the whole thing is like you have to re-register the whole thing. So I always have, I used to use, as he said, I used to put it with Mayfield, but I moved it away. I put it to the Jackson table.
And if you move the table, it actually moves with the table, so you're actually pretty good because you can move the table up and down, rotate it slightly if you need to. So.
Why are you doing it robotically? Lucia said you should be doing it.
So we haven't yet invested in a robot because of the cost, but maybe soon. And I think it can start with thoracic and lumbar spine, and then go up to this location. But it is a good idea to just place screws and do the fusion. But I think I would just wait. So again, here are the images initially, 6 weeks after surgery. We got good alignment of all the structures, and out of 10 months, 11 months, he did pretty well and had a good fusion with the bone graft, as you see over here, the lower two slides, out of 11 months. The same slide again. So another case, this is just a chronic type 2 fracture. In this situation, we had this 47-year-old female patient who suffered from C2 fracture type 2 I think about a decade and a half prior, and they had managed her conservatively. She was doing fine, didn't have problems, but then came with a new development of neck pain and myelopathy. She felt her hands were becoming weak, she couldn't use the computer, and when she got evaluated with detailed imaging, as time went on, they found fracture and mobility. So she was referred to us for the dense fracture, and when we did flexion extension, she's got significant mobility at the occipital C1, which appears to be 1 unit, and the body of the dent seems to go backwards significantly, I think by about 7, 8, 9 millimeters. I can't make out, but it was causing cord compression. On exam, she didn't have deficits, but subjectively or while work or certain positions, she clearly had symptoms which were causing a problem for her. And she has a history of steroid use in the past. So, on extension, this chronic fracture reduced, so it was significantly mobile. On flexion, it moved, it retroflexed by about 7 or 8 millimeters. This was the MRI which showed stenosis causing the radiologist read some myelomalacia, and you can see sort of the hyperintensity on the axial scans, sometimes called snake eyes just because literature refers to it that way. But you can see the hyperintensity within the cord bilaterally, and a significant amount of stenosis compression at the CV junction. So in this particular patient, she didn't require extension to the occiput. This was an ideal case for a C1, C2 fusion. These images are intraop images. They just show dissection of the nerve roots under the C1 arch. This is where you get most of the bleeding while you're dissecting the nerve roots and getting down to the lateral mass. Usually you're pretty safe about 11 millimeters on either side of the midline, both above and below. You've got the vertebral arteries, which are laterally at around 10 or 11 millimeters. So you're safe to dissect both the arch laterally below as well as above. Some of the surgeons use what's known as the palm technique. That's the posterior arch lateral mass technique, where because of the blood loss of the anatomy, they don't dissect the lateral mass out. They try to insert the screw into the posterior arch of the atlas, going into the lateral mass, and it's known as the palm technique. If the morphology permits, and you've got a good posterior arch, you can do that with the help of fluoroscopy and navigation. I've done it in a few of the cases where I felt, dissection of the lateral mass was causing, significant issue, and they do well too. So either one of those techniques works really well. And then again, the same slide on the other side. You've got the neural ligaments in the midline. And MRI is a pretty good method if you have a good radiologist and they can actually identify tears in the posterior ligamentous complex and CSF leaks. When they have said that there's possibly a tear in the CSF leak, we actually visualize that after we've dissected the C1, C2 region. This is a case where I've used iliac crest autograft. You can see that between C1 and C2. We placed C1, C2 screws, and then the Sontag cable around the iliac crest autograft and the C2 arch to hold it in place. And again, intraop images as well as post-op images showing the C1, C2 stabilization. This is immediate post-op, and I think this is at 3 or 9 months. It was not sure. This is another patient. I just brought it here as an example. It's not possible in all patients to get a good reduction when we flip them, and they continue to remain unstable. Okay, you can see there's a significant degree of translation between the fractured dents and the body. Okay, and sometimes it's just not possible. No matter, sometimes perfection is the enemy of good, is what they say sometimes. So you got to be happy with what it is. The good thing about CV junction is that there's a good amount of space over there. So the cord is relatively safe, even though this looks, like it's going to be compressed. Amazingly, they have neurological function and motor and sensory work potential remain good. So in this patient, it was really difficult to get this to reduce just because of the way the fracture was. It looks like the tip of the dent is actually impacted into the body, and these are tough fractures to reduce unless you distract gently and then try to get them back to their morphological alignment. So he was sort of prone. they reduced slightly as compared to the pre-op. You can see it's impacted. This is the O-arm image that we have. Reduced slightly maybe over there with a slight disimpaction. And these are our final images with C1 to C4. This patient's bone quality wasn't too great, so I had to extend my fusion. As you can see, there's no lateral mass screwed here at C4 because the lateral mass broke out. So I was concerned about his bone quality. And this is the connector between the C2 screw as well as the rods. Sometimes you have to use connectors to get that alignment or to connect to the rod. So at UF, I've done 40 patients over my 6 years, and we are still looking at the data. This is just incomplete, it's a brief overview. We wanted to look at fusion rates in patients younger than 65 and those over than 65. We are still looking at the type of graft material, the type of the operative blood loss, the duration of surgery. So all that data is not yet there, but I'm working with all my postdocs, and hopefully come out with a publication soon. But we did 40 patients. Less than 65 were 22 patients, and more than 65 we had 80 patients in this series. And we had a fusion rate of 70% in those who were younger than 70% overall fusion rate, 72% in those younger than 65, and about 66.6% in those older than 65. So the fusion rates for us remained around 70% on average, irrespective of the age of the patients. That's what we found. And we had about a 25 to 30% non-fusion rate. What does that mean? Does that mean we take these patients back up for a revision or surgery? Not really. For those who didn't fuse over the period of the 6 years, we just followed them up with imaging. And some of the patients, nothing really changed. They were doing clinically well and they were doing radiologically fine, so we didn't go back and do anything with them. And also, with time, they aged. So it made it more risky to go back in and change things. So I think this is a pretty fair result in terms of fusion. And what would I recommend now? If a patient can be operated and is sort of agreeable to the limitations with the C1-2 fusion, and that seems like a safe approach to you, I would think that surgically stabilizing them would overall give them more of a benefit, get them out of bed, chance of removing the brace and the orthosis, getting them back to leading, as much of a normal active life. So my preference is to surgically stabilize them, decompress them if needed now, versus prolonging the orthosis or the halo vest immobilizer. Thank you.
Well, we asked you so many questions already, but we can certainly take a few more.
I'm sorry, go ahead.
I have a question. Do they have massive headaches, like occipital headaches?
They do, especially when the C2 nerve is compressed. They come with severe occipital neuralgia, and sometimes, wherever they got seen, they get sent home with a collar thinking that it's okay, but they go back and they have severe neuralgia, especially when they extend their neck. In those cases, I section the nerve root when I do the procedure, the C2 nerve root, and that helps.
They do well?
They do well, yes. Yeah. And I didn't mention it, but again, there's controversy regarding preserving the C2 root, resecting the C2 root distal to the ganglia or not. I haven't seen much variation in the results. If you think that there's not much space and you want a good fusion at C1-2, you can resect the nerve root to place bone graft down in the junction. If you feel that you can place enough bone graft lateral and medial on the C1, C2 and you've got enough bone, I don't resect it sometimes. I use what's known as shank screws, partially threaded screws. So it's got about 14 or 16 millimeters of thread that goes into the lateral mass, and the remaining 12 millimeters is smooth, so it doesn't really rub against the C2 nerve root or cause neuralgia or issues.
Jeff?
Is 9 months your standard for a halo?
For me?
9 months, is that your standard duration for a halo?
If
I saw a couple of patients.
So I didn't use the halo for 9 months. Patients will not tolerate 9 months of a halo. So it's 3 or 4 months if they can get the halo on. Sometimes at 8 weeks they come back and they have inside infections or they are unable to wear that. So from there I moved over to a CTO brace if the X-rays look okay and if they are aligned, or else convert to surgery. this was just one of the patients, but it was just as an idea, it could take that long for fibrous union to take place, because when you do a flexion extension, you don't want to see that moving. So yeah, I follow them up for that long, for 9 months to a year.
Thank you again. Dr. Watts, you're up. So Dr. Watts is the Chief of Cardiovascular Surgery at St. Joseph Medical Center. He's going to talk to us about anterior lumbar spine exposures. Dr. Watts, you're going to tell us why we should be doing it as surgeons and why you should be doing it for us, or what are you going to say here? We'll have to wait to find out.
I'm gonna let you be the judge of that. All right, so thanks for inviting me here today. I don't have any disclosures. What I wanted to talk about today was anterior lumbar spine exposure. And basically what the access surgeon, i.e. myself, what we're thinking about when we're getting you guys down to the spine, because I know all you care about is the spine, and that we get you down there safely, but I wanted to let you kind of run through kind of what we're thinking as we get down to the spine for these procedures. So really just wanted to go over some of the anatomic considerations that we're thinking about, how we approach it, how we should be approaching it in a way that is safe and really reproducible. There's talk in the literature about the transabdominal approach, which I kind of think is rather silly to do in most cases. Why go transabdominally when you can go retroperitoneal? It leaves the patients with a belly that's been operated on for any future approaches intra-abdominally that they need. So the retroperitoneal approach is really what we stick to most of the time. It can be done in people who have had previous C-sections, previous intra-abdominal procedures, and really it works quite well. Now, in those people who have had previous procedures, you can see scarring of the iliac vessels, which sometimes makes it more treacherous. Just kind of to go through things, for really L5-S1, we'll typically stay below the umbilicus. If we're at L4, L5, or clearly if we're up higher above L4, we'll go up above the umbilicus. But typically for L5-S1, we can stay below the umbilicus, and really want to emphasize how important just the abdominal wall structure is, and really the rectus sheath, because what we want to do is cut down to the rectus sheath and enter the anterior rectus sheath, and then go out laterally and get into this plane here. So this is the plane that we're working in as we go down to the spine. Once again, really just the rectus sheath and how we're going to go out laterally here. And what that's going to allow us to do is identify the psoas muscle, and then start looking for our ureter, the iliac artery and vein, and then actually the spine, which is again what you guys really care about. When we get to the spine and the iliac vessels, really there are a few things that come into play, and when we're down around L5-S1, we're really concerned about the median sacral artery and vein here. When we start working up around L4, L5, and are going to retract everything medially, we not only have to worry about the segmentals to that segment, but also the iliolumbar vein, which if you traction the iliac vein medially, you can tear that, and that can become very, very difficult to fix because it'll retract out laterally and bleed like stink. So again, just an illustration of the median sacral artery. Again, as we go up higher, at this level, probably L4, L5, we're maybe slightly above the umbilicus, and clearly if we're going up here, we're going to be above the umbilicus. But for many procedures, it's really kind of sub-umbilical or just above the umbilicus. Again, on the venous side, once we get up here, we want to retract the cava medially, and doing that can often, once again, traction the iliolumbar vein, which is something that we need to identify and clip. Here you'll see is kind of our main structure that we use to help kind of identify things. The psoas muscle, you'll notice that when your access surgery kind of gets into the rectus and we start going out laterally, we're going to go lateral and inferiorly, because basically with sponge sticks you can develop this whole plane, and this should come into view as you develop the retroperitoneal plane and bring it all medially.
Do you do any specialized preoperative imaging, or you just go by with whatever the spine surgeon is?
Usually not. I mean, I trust you guys most of the time, and we'll look at the films beforehand. Recently, having said that, we had a case where the iliac vein was oddly very medial and was stuck right in the middle of L5-S1, and this person had a C-section before and just couldn't really peel it off safely, so ended up flipping the patient, and the spine surgeon went laterally. But, you know, in my opinion, 95% of the time you should be able to do this safely, and if you run into something that just doesn't look right, I mean, you should have a bailout plan.
And just curious, your distribution of exposures, how many times do you have to go? I'm really asking how many times you have to go to 4 or 5 in your experience. Is that a common occurrence? Because
yeah,
I've just given up. I just, if I have to go 4 or 5, I don't even try for the anterior.
Really?
Yeah.
I'll do a lot of 4 or 5.
Yeah.
And I've done, there are a couple of the folks that I've worked with that will go up higher. My people, you know, we're not going to do it on a morbidly obese person. I think that's kind of asking for trouble, but with an appropriate body surface area and someone who's pretty much got virgin anatomy.
I work with Dr. Watson. But Dr. Watson and I have done a lot of approaches together to 4 or 5, maybe.
Yeah. I mean, it's pretty
It
complicated.
really depends on your CV surgery. Dr. Watson really sounds like
3-4 is almost easier. Like going higher is almost easier. Going lower is certainly easy. It's just that 4 or 5.
Yeah.
So I don't mean to jump ahead, but you're going to talk about what to do when you get into the iliac vein.
Yes. Well, I'm going to.
Not that you ever do, but the lesser surgeons might.
Right. So what I would say is, you know, I feel really strongly about slowing down to take the, you know, do the right things at the right time. So I think there's a culture in a spine exposure surgery that you got to be fast, and yeah, you got to be fast, right? But or you guys would never call us. But I think that when you're around L4, L5, and you're looking for the iliolumbar vein, which is really the thing that spooks everybody, you got to take your time and expose that. So we'll take our time, we'll expose it, we'll clip it, we'll ligate it. So 2 is better than 1, in my opinion. So we'll ligate and clip it. And pretty much when you do that, I think the segmental vessels to each level don't bother me at all. I think it's really the potential for the iliolumbar to retract out laterally and have a hard time finding it, because, you know, we're doing these things sometimes in an ASC and not in the hospital, more often than not in an ASC. And when you start asking for clamps and you know, fluoroproline, people are freaking out by that point. So I think slowing down to get the appropriate structures dealt with is the key. So again, for 5-1, we're really just ligating the median sacroiliac vein, which is pretty straightforward. But it's really when we get up here that everybody's finger tone tightens up a little bit. And again, working down here to control the iliolumbar vein is really the big deal. If you get into the iliac vein, as anyone who's done this knows, you can lose a lot of blood very quickly. So all these people, you know, we have cell saver with, oftentimes when you're doing this, you're kind of in a hole. So sewing and tying can be a little bit more challenging, and we'll often use clips. So, you know, if you get a hole in the iliac vein here, putting on a clip in kind of a triangular way, kind of one down here, one up this way, kind of clips off that hole. And putting sutures in it can oftentimes be really technically challenging, no matter how good you are at it. So,
The ones you get to tearing are the morbidly obese patients. which are the most, in my personal experience, which are the most difficult to close. And I've actually had the experience where we had to sew the iliac vein to the anterior longitudinal ligament, just essentially take the iliac.
Right.
That's after like a 4-liter blood loss in about 4 minutes.
Right. Exactly. So, yeah, I mean, you can see that. I haven't had that experience, but I think that that I'm one of those people that, like I said before, in the patient who had this really medial iliac vein and it was scarred down, I just said, look, it's just not worth the risk, and we're an ASC doing it. So, you know, you should have an alternative plan, but that doesn't happen very often, really. So just kind of an image of doing 4 or 5. You know, people use different retractors. To be honest with you, the retractors in these images, I don't think we really often use. We'll usually use either Omni, where you have everything set up and self-retaining, or just some Wileys. So if we're at 5-1, we'll use 3 Wileys and a Steinman pin. So putting a Steinman pin over here to hold the vein out of the way, a Wiley here, a Wiley here, and a Wiley up here, and typically the spine surgeon can see just fine. So what are some anterior lumbar spine exposure complications? All these things that you folks all know really well: ileus, wound infections. Some of these folks can get retrograde ejaculation or neurologic problems. Surgical site infections, as with any surgery, misplaced screws, hardware malfunctions. Just a little bit about retrograde ejaculation, what it is. Some of these patients actually will be able to reach climax, but they have a little bit of ejaculate that actually comes out, versus delayed ejaculation, which can also happen in these folks. And really, these are really thought to be due to the plexus of nerves that lives down here, the hypogastric plexus. And I don't know about you, but I really kind of have a hard time seeing those most of the time. But they're there, and it's reported. So we'll try to avoid using Bovie if we can in that region. We'll typically use peanuts when we're pushing all the tissue out of the way on top of the disc to try to minimize that. And again, just talk about the plexus. There's several medications that have been used to treat retrograde ejaculation. I'm sure all you folks have much more experience with how effective they are than I do, but just thought I'd list some of those. And you know, really the literature that I looked at in terms of the medical treatment is a bit dodgy. I mean, there's not a lot of good treatment out there. So the best treatment is to avoid having a problem in the first place. And lastly, I would say that although we have a pretty good understanding about retrograde ejaculation and those complications in men, in women, there's some data to show that up to 40% of patients can have changes in their menstrual cycle and their sexual activity after having spine exposures, especially down around L5S1. So just something to bear in mind.
We use, number one, we use the general surgeons primarily, but they've gotten so busy doing these. And frankly, younger generation of general surgeons, they're so highly specialized, they don't want to do approaches.
Yeah, they're so specialized in doing only laparoscopic this or only robotic this that they're not as comfortable with doing these because, the blood loss that you can see spooks them.
Yeah. So we're using our cardiothoracic, we're using our vascular surgeons now who seem to be happy to do it. There is a confidence factor if you get into the vessels. That's pretty. Yeah, I do want to say, you made the point. If you get into an arterial bleeder, usually closing that is somehow very straightforward.
It is. Yeah, it's really the vein because, and that's what we, I trained a while back, and at Ben Todd in Houston, we would see people that get shot in the iliac vessels, and fixing the iliac artery is not a big deal, but the iliac vein is a beast. So staying out of it is the best prevention, I would say.
Question? Thank you for your service to us. Can we have Dr. Rao? Dr. Rao, thank you. Dr. Rao is going to speak to us about the surgical mission trip to Honduras and the hand surgery cases that he performed there. And then I'll go next, and then we'll wrap up with Dr. Sarah, creating income. Is Dr. Sarah? Very good, Sarah.
Good morning to everyone, and thank you for having me today. Really enjoy being here. I've been to Honduras for the last 2 mission trips, and I thought this would be a good opportunity to talk about it. I have no disclosures. I've always wanted to go on a mission trip, but I had no idea how to get about going there. On one of our ICS meetings, I bumped into Dr. Alvear and found out about the World Surgical Foundation. And this was sometime in 2018 or so. And the next year, I went to Honduras with the mission trip. I had no idea where Honduras was. It was somewhere in Central America. And that's as much as I knew. Now, the World Surgical Foundation has mission trips to other parts of the world, Africa, Philippines, and all of those things. And I had just come back from a very traumatic trip to Turkey. You know, it was just a terrible trip, and I said, I'm not crossing the Atlantic anymore. We'll stay stateside. So that's why we picked Honduras. The place we went to was called San Pedro Sula. Again, this was all new to me. San Pedro turns out to be St. Peter in Spanish. My wife looked up the place and she says, better be careful because it's also called as the murder capital of the world. So again, I had no idea what we were getting into, but we went there. And we had a phenomenal group of people from all over the states, virtually everywhere from the East Coast, West Coast, Texas, everywhere. And I think we were about 30 of us representing, many specialties, physicians, nurses, allied health professionals. The hospital that we worked at was just a small general hospital. To enter, you had to go through that gate with an armed sentry every day. The nursing staff out there, the OR scrubs and the circulators, they did not speak a word of English, and most of us could not speak any Spanish at all. But we got by. I used Google Translate quite a bit, but they picked up very well. Despite the fact that they're from a different system, different country, I found them to be extremely intelligent and capable of picking up everything that we had them do. We also had local physicians help us, the anesthesia providers, local interns, medical students, they all helped us tremendously, and I was very impressed with the kind of medical service that we got from the local people. There was a lot to be said about the actual instruments and equipment that we got. Being an orthopedic surgeon, we are used to all kinds of tools and toys. The best we could get for power equipment was that DeWalt drill. We could use it once a day, and that was it. After that, it had to be gas sterilized. So those were the challenges we ran into. The hospital was not well equipped. And you know, we've always heard these horror stories about mission trips where you have to live in tents and use you know, outdoor bathrooms and stuff. This was not the case. You know, our hotel was probably 2 or 3 star. This was the view on the left as we got out of the hotel. We looked at a mountain, beautiful sky, warm weather. And in the evening, we were usually hosted, wined and dined by, you know, some local celebrities, and we really had a good time outside of the work environment. There was time for R&R. You know, we had a beautiful pool, beautiful recreation area, and the hotel itself had a phenomenal lunch and breakfast buffet. So from that standpoint, the mission trip was very well organized. Now, that being said, I just want to focus on, you know, some of the cases that we did while we were out there. So I went there first in 2019, and then COVID happened. So we had a break period for about 2 years when nothing happened, and I went back again in 2022. So this sort of talks about the 2 mission trips that I've been. So in the US, if you practice hand surgery in a non-academic setting, majority of the cases that you would do, not all of them, but most of them, the bread and butter cases will be, you know, carpal tunnel surgery, trigger finger surgery, a lot of arthritis surgery, and of course, depending on the kind of trauma situation you're in, you know, you would treat fractures and tendon lacerations and those kinds of things. So that would probably be about 70–80% of hand surgery cases in an average private non-academic setup. Well, in Honduras, it's totally different. You see a lot of congenital cases, you know, syndactyles, you know, duplicate thumbs, those kinds of things. You see a lot of neglected cases, you know, people who've been injured with machetes or, you know, electrical burns and those kinds of things. They never get treated, and then they land up at your mission trip with some horrendous problems. And you also see a lot of neuromuscular cases, you know, CPs, arthrogryposis, basilar plexus injuries. The sheer volume of these cases that you would see in a week is just amazing. You know, I worked at a children's hospital in Cincinnati, and I wouldn't see these cases in a year. But in the span of 1 week, you can see the whole spectrum of cases. Amazing pathology. So what you would really need for basic hand surgery in an average setup would be something like a hand table, you know, a lead hand, tourniquets, basic fine instruments, basic fine sutures. None of these were available. If you took it one step further, you know, you could ask for things like C-arm, fluoroscopy, power equipment, Kirshner wires, adequate dressing and casting material. Again, these were hard to come by. So for my second trip, I just packed together some basic instruments, as you see on the right side, took it with me and had them sterilize it every single time we did a case. So that made things a lot easier for me. Otherwise, it was a struggle even doing you know, simple things out there. That was our surgical team. You can recognize Dr. Mark. And the lady in the center was our star circulator. She made things happen. It was an amazing time, I can tell you. So I'm just going to go through a few cases that we ran into, and then we will talk about you know, some of the surgical tricks and techniques that we use. So this was an 18-year-old boy who actually works at the hospital. He had an electric burn when he was a child, completely burned his hand, and he had a thumb that was contracted, was basically a thumb in the palm. He couldn't use it, and this was untreated until he ran into us. So, you know, a 2-year-old with an untreated radial club hand, duplicate thumb, syndactyles, again, neglected post-traumatic contraction in the hand. We saw foot cases as well, congenital hallux varus, again treated elsewhere, didn't get better. 7-year-old child with arthrogryposis has never walked. She came crawling to us. Again, neglected trauma. This girl had an open fracture with infection, never healed, came to us. Same thing, neglected trauma. So these are the kinds of cases you run into, and you sort of have to be prepared to treat all of these in less than perfect conditions. So I'm going to talk about syndactyly because this is one of the things that we see quite often out there. The syndactyly, as you probably know, is otherwise commonly known as webbed fingers, and this is failure of separation of digits around 6 to 7 weeks of intrauterine life. They are classified as either simple or complex. Simple meaning that they are just webbed with skin. Complex syndactylies have skeletal elements that are fused, so you can have phalanges or joints that are fused in both of these digits. They can be complete, meaning it involves 2 or more digits from top to bottom, or they can be incomplete. Many syndactylies are isolated conditions, but more often than not, they can be associated with other congenital anomalies and oftentimes multiple syndromes as well. So you have to treat them at an early age, usually around 1 to 1.5 years of age. You start operating on these folks, and typically you should complete the treatment by the time they are of school-going age. So there are certain basic principles about treating syndactylies. You have to separate unequal digits first. So if you have, say, for example, index finger and thumb syndactyly, both those digits are unequal in length, you have to separate those first. You don't want to operate on both sides of the digit at the same time because you can risk neurovascular compromise. You need good loop magnification, you need good tourniquet control. You can't take too long to do those cases, you have to respect your tourniquet time. The basic principles of separating webbed fingers are pretty well established. You have to make zigzag incisions, you can't make straight incisions. It's really important to reconstruct the web between those 2 digits because those are the things that cause problems as they grow up. So the web is always reconstructed with a big dorsal flap. You have to expose the neurovascular bundle and make sure that each digit has adequate circulation. If you run into a situation where both the phalanges are fused, you have to separate those 2 phalanges with an osteotome. Oftentimes the nail is common to both digits, so you have to split the nail and reconstruct the end of the digit with local flaps. Always release the tourniquet, make sure that you have adequate hemostasis. And these little kids have a lot of subcutaneous tissue in their digits. Unless you defect the skin, you won't be able to close the skin properly. Now the thing to understand is, when you have syndactyly, there is always a skin deficit. So when you separate the fingers, you will always have some raw area that has to be skin grafted. The graft is usually taken from the groin area. Sometimes it's possible to cheat a little bit, so you can always bias your flap more on one finger than the other, so you can use more skin on the dominant digit that you separate, and therefore you will have less skin graft on that dominant digit. So you have to use absorbable sutures. You have to immobilize these kids in a cast for about 2 weeks. And at the first dressing change, if you find that some of the graft has not taken, the best thing is to take them back and regraft it, because if you let it scar down and heal by secondary intention, the outcome is not good at all. So it's better to be proactive and aggressive in these cases. So here's an example of a simple syndactyly. So as you can see here, we've taken, this is the big dorsal flap that we talk about. These things have to extend to almost the first 2/3 the length of the dorsal proximal segment. And then you make these zigzag incisions, which are actually mirror images on both sides. And once you transpose these flaps and suture, They cover most but not all of the digit. And then in all these little small raw areas, you have to put a full thickness skin wrap. This is meticulous, this is tedious, it takes a lot of time, but you have to do it right the first time. This is a little bit more complex because now you have this child who is probably about 2 years of age. That's the thumb, that's the index finger. Ideally, you have to separate this as quickly as possible, otherwise the thumb will not grow. So we took this child to surgery right away. So you really have to do a very radical release of the first ray, and that could include going all the way down to the joint as well. So that's the kind of separation you have to do, just filling the whole thing open. That big defect that you see there has to be filled with some sort of a flap. You cannot use a free skin graft. In small children, you can get by with a local flap. If you're doing this in older patients, and we'll see a case later, you have to use either a free flap or a groin flap or something of that sort. What we did was we simply transposed flap from the dorsal of the hand right there, and put a full thickness skin graft. So you can see now that the thumb has been separated from the index finger, and it's more in line with the normal thumb, which typically is at about 80 degrees from the surface of the palm. And I actually had a chance to see this guy 3 years later when he had come back for separation of the syndactyly, but that's his thumb. Doesn't look bad compared to what it used to be. The problem with all of these kids is follow-up, because once you leave the mission trip, after a week, there's no way of seeing them back again, but I was fortunate to bump into them again. So let's talk about radial club hand. A radial club hand is a congenital anomaly. It's defined as a preaxial longitudinal deficiency. It basically means that the radius does not form. So you essentially have a one bone forearm. And what that does is, you have a short forearm, you have a wrist joint that is totally unstable, and you have a hand that is deviated about 90 degrees or so. These are usually sporadic cases, but about half the times, they are associated with some sort of congenital, multi-system abnormality. And these could include musculoskeletal, genitourinary, cardiac, respiratory, all systems. There are some syndromes that are well known with radial club hand. One is the thrombocytopenia absent radius syndrome, and usually these kids have a low platelet count at birth. But the count generally improves, so once their platelet count improves to over 100,000 or so, it's pretty safe to operate on. Fanconi syndrome is another condition which is associated with the radial club hand. Unfortunately, most of these kids have a fatal outcome. You have the Holt-Oram syndrome with an atrial septal defect, and you have a well-known condition called as Vater or Vactor syndrome, which is vertebral anomalies, anal atresia, cardiac anomalies, tracheoesophageal fistula, etc. And these are often associated with a radial club hand. So these are things that you ought to know, and oftentimes these are questions that are asked on board exams as well. So coming back to the radial club hand, about 50% of them are bilateral cases. The thumb is usually, but not always, absent. Most of them are born with a stiff elbow, and because the radial aspect of the forearm is deficient, it's not only the absence of the radius bone, but all the soft tissue structures, such as the radial artery, the radial nerve, some of the radial placed muscles, they are all absent. Many of them have multiple abnormalities in that upper extremity, including the upper limb, the chest wall, multiple deformities can be present. So when you treat a radial club hand, obviously you have to look at the whole picture, and you want to make sure that there is nothing else going on. So this is usually a multidisciplinary approach, and these kids have to be treated for all associated conditions as well. But coming back to the forearm, you start off by serially stretching the elbow stiffness and splinting the wrist in a better position to make them ready for surgery at a later age. So there's a classification by Bain, which is commonly used. This has been modified numerous times, but this is still very relevant. Type 1 is just a short radius, and progressively more deficiency in the radius. As you go further down the line, you can have a hypoplastic radius. Type 3 is almost complete absence, and type 4 is a complete absence of the entire radius wall. So just to give you an example, this is a type 2 with a short radius. Again, you can see how the hand is deviated. Type 3 radial club hand, you just see a small remnant of the radius out there. And in a type 4, there is complete absence, and all you have is a hypertrophic ulna. So what happens when you have a radial club hand is you have a short forearm. You have an elbow that is completely stiff without motion, and all the motion takes place at the wrist joint, which is dislocated. And because they have an absent thumb, that hand is pretty much useless. If it's a unilateral club hand, that limb will be non-dominant. They will always use the other limb as the dominant limb. Bilateral club hands, those patients have problems with prehension, with reach, with grasp. They still manage to function, but obviously they'll never be as normal as somebody with a normal limb. So treatment is essential. It is recommended that we start around 1 to 1.5 years of age. So after you start the normal stretching and splinting, at around 1 year of age, you have to do what is called a centralization, and we'll talk about that in a second. The second step would be to create a thumb, and that would be index finger policization. As they get older, they oftentimes develop a bowing deformity of the forearm, which can necessitate either corrective osteotomy of the ulna or actually lengthening of the ulna. Some people have tried a prefibrillar artificial transfer to replace the radius, but in practice, I don't think this has ever worked very well. So centralization is the procedure of choice. So the surgical principles for centralization is to open up the radial aspect of the forearm, excise all the fibrotic tissue, lengthen contracted tendons. The first thing that you actually see when you open up the forearm is a nerve, and that is the median nerve. It is placed more radially than normal. Do not mistake that for a tendon. Do not cut the median nerve. That's important. And then you have to make a second incision on the ulnar aspect of the wrist, shorten the ligaments, tendons, and realign the wrist with the second incision. So here is an example of a type 4 radial club hand. So through the radial incision, you sort of lengthen all the contracted tissue, excise anything that may be tight, and then through the ulnar incision, you shorten the ulnar aspect of the forearm, and then you place a long Kirchner wire or a Steinle pin to stabilize this wrist. A lot of people, including me, will leave this thing for the rest of their lives, because if you decide to pull it out at a certain age, almost always the wrist will deviate. So there's no harm in leaving the Steinle pin forever. They will have a stable, neutrally aligned wrist, and down the road you can go ahead and reconstruct the thumb, and they'll have a perfectly functioning hand. This is another one. This was an older child, so we actually had to do an extensive Z-plasty to lengthen the skin. And again, you have to make an ulnar incision to sort of realign the hand and shorten the lengthened tissues out there. Now, unfortunately, we don't have follow-ups on all of these because we haven't gone back again. let's come to thumb duplication. This is again pretty common. This is more of a cosmetic problem because kids who have duplicate thumbs can be completely functional. They don't have any difficulty using the thumb, but it looks bad. So many of them come to you to have it surgically treated. When you have a duplicate thumb, neither of those two thumbs are normal, but usually the one on the ulnar side is more functional. So the one to remove is the one on the radial side. Again, this is associated with a certain degree of thumb hypoplasia, so they may have deficient tendons and muscles as well. And the plan is pretty simple. You remove the less developed thumb, which is usually the radial one, but you want to retain the soft tissue structures to reconstruct your collateral ligaments and reattach the muscles as well. It's a very simple classification by Wassel. It is based basically on the level of division of the thumb, whether it's in the terminal segment, proximal segment, or the metacarpal level. So in a type 4 duplication, you have 2 terminal phalanges and 2 proximal phalanges, and 1 metacarpal. Again, you fillet the whole thing open, you remove the radial part of the thumb, but you have to preserve all the muscles and tendons, and then reattach it. This child also had a thumb web space contracture, so we did a Z-plasty to open up the web space. And this is on your plate. Type 3 duplication, which is, they have a partial separation of the proximal phalanx. Again, you can see that the radial digit is smaller than the ulnar one. You can excise the skeletal part, but retain the collateral ligaments and the abductor muscle. And this is skin closure. So, going back to the first case that I talked about, this was this 18-year-old with a severe thumb contracture, and this is a case that I did with Mark. So, after we opened up his thumb web space, there was a huge, huge defect that could only be covered with a radial forearm flap. And this was his 3-year follow-up. And I think he had a second surgery, didn't he, Mark?
He did,
yeah. So it was pretty gratifying to see him 3 years later. He actually waited for us when we showed up, and I was pleased to see him. So in the end, I have to say that I've been there twice, and I probably will keep going back again. It's important to know that we are so fortunate to have so many good things living in this country, and you don't know what we miss until you go out there. So I'm just going to close by these 3 statements that ring true every single time I go there. And Winston Churchill said that we make a living by what we get, and we make a life by what we give. This is an old one that I've known for a long time. I cried because I had no shoes until I saw someone with no feet. And you see this time and again in these impoverished countries. You see people that have absolutely nothing, and they still get by, and they always have a smile on their face. We all know this, charity begins at home, but it should never end there. This is what we get for treating some of our young patients. Thank you. Yes.
So we all got there on Saturday. On Sunday, I know I made rounds. I was at a different hospital than you and Mark, so I had no idea what you guys were doing, and vice versa. But the question is, I made rounds on Sunday. I basically saw all the complications that we were going to deal with for the week. Did you and Mark also see everybody on Sunday that you were going to operate on that week?
Yes. So Sunday is when they all line up and we sort of see them and we pick out cases and schedule it for the rest of the week.
And the other question I had is that I was working with some local surgeons.
Yeah.
You guys were not, correct?
Well, we had one local surgeon who corrals the cases and brings them over, and he works with either of us. And sometimes I have an intern or a medical student who scrubs with me, but
So I was curious, who's gonna pull the pins out and who's gonna?
yeah, so we have one local surgeon who does that.
Okay, that's what I was.
We couldn't do this without some local
Right.
support. Absolutely not.
The only ethical way to do this is to have a local champion to cover your head.
Well, we had a lot of the families down there were very much local champions, like Layla, and everything else, but as far as physician champions,
No, you have to have one physician person.
That's what I had.
Plus, where you pick to go, you should pick a location that has a local physician champion, because your job is to really teach him or her how to do what you do. So the main goal of the surgical mission is we just all out of business at that grant.
Right, well, that's what something was when they showed you 15 or 20 patients, you go, what would you do for something like this?
Right. So you have to identify a local physician champion.
Well, and the big challenge is that you have to pick your cases. You can't do something that is going to require prolonged aftercare, because you have no idea what's going to happen after you leave. And the last thing you want to do is do an operation that requires multiple subsequent procedures, and you're not there. And I can give you a classic example. We had this 18-year-old boy who walked into the office with an MRI scan. He's a soccer player. He's ruptured his ACL. Young guy, wants it fixed. And there's no way in hell that I would do an ACL reconstruction in that hospital with nothing. I had to send him away. There's no way you want to open up the knee, try to fix something, and then let it go halfway. It's just not possible. So you run into these situations where you want to help them, but there's nothing you can do.
I mean, we had the same thing. I worked at the trauma hospital, the biggest hospital in the city.
Yeah.
And the most sophisticated imaging they had there was X-ray. And they had a CAT scan that hadn't worked for at least 6 months. And the MRIs that were in town were always freestanding. And even for hardware, they would get a prescription from the doctor there, and they would go to 1 or 2 places in town where they sold pedicle screws or rods and things like that, and they would go to that place, they would pay for their screws and rods, and on the day of surgery, somebody from that company would come, show up in the OR with trays for what they paid for.
Yeah.
But if they wanted to get an MRI, they would have to get a ride first to the MRI place, or a CAT scan place, and then pay for the CAT scan or MRI.
It's true.
So it was very sad.
Thank you.
That's a tough act to follow. That was a beautiful talk. Those quotes were fantastic. Thank you. I'm going to talk about something completely different. Yeah, posterior lumbar instrumentation. Every time I give a talk like this, for me, it's been about 30 years of doing this. And one of my friends, when I give talks like this, I asked my friend, I said, well, what do you think? And he says, well, it's good to have a science project or a hobby or something like that, meaning that this is something that I've embraced for many years, but it's really taken a very long time to make any forward progress. So no disclosures related to this talk. I do want to put a plug in. I guess we're meeting next year in Philadelphia. It sounds like we're meeting in the historic area of Philadelphia, which is the Society Hill area, and that's where I practice. I'm actually at Pennsylvania Hospital, which is the oldest hospital in America, nation's first, 1751. So if we're there, as a group, I'll try to organize the historic tours. It really goes to show what places were like before the United States was a country, right? 1751, earlier than Texas, I think, right? Well, how about that? So 20-year endeavor, actually it's more, and this is the main driver. We all learned how to do fusions when we were residents and fellows.
But most of us do find the idea of maintaining motion more appealing and more compelling. And as we've become interested in this, we've understood that the biomechanics are quite involved, and we've gotten a better feel for the biomechanics. We've gotten a much better feel for what's required for structural integrity in these devices. We all looked at the total disc replacements, the anterior lumbar approaches. I've done two, and I didn't even do them alone. I did them with my partner. That's for lumbar. That's my total extent of total disc replacements. And I don't do them. I won't do them. And I've just found them to be difficult. There are a lot of complex biomechanics that you can't always take into account. And what I've found, at least for total disc replacements, is that there are a few people that are very interested in them. And when a patient says, I want a total disc replacement, I refer them to my colleagues. But I have followed and helped to develop posterior devices over the course of years. I do incorporate them into my practice, and what I'll present to you is my experience. The TOPS device is very close to being FDA approved, so I think that once it gets insurance approvals, I think that you will all be seeing that and probably doing that. Prior to the TOPS, I worked with Zimmer on the DNASYS system. That was really the first pedicle screw-based posterior system that didn't require fusion and did perform a fusion. The issue with that is that nobody really understood the biomechanics. The flexible rods weren't that flexible, and they were about as strong as small rods from years past, basically making a semi-rigid system. They're so stiff. I actually have an article in preparation showing that you can get quite a solid fusion with the DNASYS construct, obviously much too stiff. And the FDA panel did not feel that it was safe enough at the time, and this was probably 10 years ago. The FDA the company brought it to FDA panel, and the FDA turned it down. As soon as the FDA, it was very interesting, if you've ever been to an FDA panel, you're in a room, you present to the panel of physicians. As soon as they turned it down, about 6 people got up and ran out on their cell phones. They were the other company representatives. Every single one of them, Globus, Spineway, Medtronic, every single one of them called the results into their companies and basically canceled further development of posterior fusion systems, with one exception, the TOPS device, which is interesting from a corporate perspective because I was involved in the trial from the data safety management probably 25 years earlier. The company went bankrupt. It was bought, and the Premier Spine was able to get enough funding to run an FDA-approved trial, which is what I'm going to present today. So these systems show promise in that they allow movement, and increased stability, with the hope that you don't have a negative impact on the adjacent level. The company bills this as a facet replacement. I've never really bought into that. I think this is a motion preservation device. It's not a reconstitution device. You don't get more motion with it. You just preserve what you had before surgery. And all these devices are built to allow normal flexion, extension, rotation, and lateral bending. The technical component of this is that there's a very, very much a neutral position for these devices. When you put these in, as opposed to just putting in pedicle screws today, if you're doing a solid fusion, you don't have to be all too precise with regards to the screw heads and the screw head location because you're doing a fusion. With these systems, you cannot pre-stress the system. They have to be put in a neutral position. So the screw heads have to be symmetric. Everything has to be a parallelogram. If you pre-stress the system, you will lose the rotation, extension, and you increase the likelihood of device failure, although to my knowledge, with this trial, there were no device failures. There's been a lot of debate about when you even would use a system like this, and I'll show some papers on the SLIP studies. It's unclear with a patient who has spondylolisthesis and stenosis if they even need to be fused. But most people, at least in the U.S., do feel that the patients require fusion of some kind. I do a lot of non-instrumented fusions, no screws and rods, but if the patient has significant instability, they require, in my opinion, they require fusion of some kind. There are appropriate surgical interventions at various stages of the disease, short of fusion, and Coflex is one of those considerations. LimiFlex is another device that's about to get FDA approval, and there are further specific patient populations. But in my opinion, these are a little bit earlier in the disease process than the group that's going to require either fusion or a device like this. We all understand the degenerative cascade, the loss of disc height and the severe facet degeneration resulting in neuroforaminal stenosis, canal stenosis, loss of movement. And you do get to a certain position when it's late stage. Putting this device in or any device is not going to be helpful for the patient. The patient probably needs a structural fusion. But you do have patients reasonably early on. We've all seen these spinal stenosis at one level or multiple levels, facet hypertrophy, primarily a sciatic component to the pain, secondarily a neurogenic component, and tertiarily a component of back pain. What do? You have multiple options for these patients. Nobody knows the right answer. It probably needs to be individualized. Everything from a decompression, fusion with indirect decompression, decompression instrumented fusion, decompression non-instrumented fusion, just laying bone on, LimiFlex, Coflex, many other options. We all understand that despite the fact that I'm talking about a device that's inserted posteriorly, the vast majority of stresses do go through the front of the spine. But the facet joints contain the sagittal translation rotation, and they resist shearing motion and probably bear more axial load as the disc degenerates. But because of this, they fail. They become inflamed, they become hypertrophy. As they enlarge due to these biomechanical influences, they can cause neuroforaminal stenosis. What to do about it? As excellent as can be done, clinical trials have looked at this, two major ones, one by Zohar Gogwala, the other by the Swedish group, and they came up with slightly different conclusions. Zohar's study said the addition of fusion to laminectomy was associated with a slightly greater but clinically meaningful overall improvement in the patient's quality of life, and he showed results about that. The Force group said basically at the end of all this that it didn't seem to make a difference at 2 years and 5 years. Leaves us completely in the mix. We don't know exactly what to do. I honestly believe, having looked at this for many, many years personally, this really is the art of medicine, the art of surgery, and it's up to the physician and patient to decide what to do. I like this system for the same reason I like non-instrumented fusions. It's not a complete commitment to doing a treatment, a laminectomy that may actually worsen the instability, or doing a fusion that may be excessively solid. This gives us a mid-position posture, and it's called the TOP system, and it's this implanted device. The trial looked at patients with up to grade 1 spinal lobe listhesis, no pars fractures. If you had a pars fracture, you were excluded. So the hospital, so the company set itself up so that they weren't doing highly unstable patients, and the patients needed to have more radicular pain than back pain, and they needed to only have the disease at one level. With those criteria in mind, and a few others, every 100 patients that contacted the company were surgeons who were interested in this device. Of the 100 that approached, 4 ultimately got randomized into the trial. So this was an extremely rigorous randomization process. The company knows, and we all know, that once this process gets released, once this device gets released, we'll use it a little bit more liberally. But you really do have to keep that in mind when you're thinking about looking at the results of this. So the company bills this as a replacement for the facet joints, and their feeling was that the facet joints should be totally resected. I just could not bring myself to do that. So I would do about a 50% or 70% facet resection. They told me my results were not quite as good as the people who did complete facet resections, but I still couldn't get myself to do it. The device itself is very, very simple. It looks very mysterious. You have this bag there, which all the bag is as follows. It's a polyurethane containment system, and you have two sliding membranes, two titanium sliding membranes that are insulated by a piece of polyurethane. That's it. Very simple. And very effective, and as it turns out, a very robust device. I don't know of any failures that this had. Very early in the construction, people would be able to flex so much that they could pull the one titanium arm and lock it over the other. That happened in about 3 patients or so, but that was extremely rare, and you can't do it with this device. So it's a titanium construct polyurethane core, allows movement to reproduce the physiologic movement that patients have. 153 patients enrolled, multi-center, 36 sites. I talked about what they were examining. The patients were followed. I have now patients at 3 years, 4 years now, 3 and 4 years out. All the patients had a single level decompressive laminectomy, midline incision, and at least a partial facetectomy, if not a complete facetectomy. We try the standard criteria up to 80 years old. The patients had to have more leg symptoms than back symptoms, but they were excluded if their BMI was greater than 40, if they had significant scoliosis, if they had lytic spondylolisthesis greater than grade 1, or if they had it at more than 1 disease level. Standard patient demographics, just exactly what you'd expect. Males slightly less than females in this particular group. And basically, I think if you take anything from this, every ODI, every criteria basically showed improvement over fusion. So the control group was a TLIF. And it was a 2-to-1 randomization. So for every 3 patients, 2 got randomized to TOPS, 1 got randomized to TLIF, and the TOPS patients fared better, basically marginally better, but better at every criteria, including back pain, which I found interesting compared to TLIF. They did better in their claudication questionnaires, and they overall did better in their safety outcomes. The key finding was that the patients who got TOPS over the course of the trial required fewer, they had no adjacent segment disease, and they required fewer operative interventions. And I'd say that's the take-home criteria here for the study. So, beyond the preliminary, we're at the conclusion. Good clinical outcomes through 2 years plus, significant improvement in the ODI, VAS, etc. And in my opinion, you're gonna see this on the market probably in the next 6 months. And I would say this has been robust, safe, and quite effective, at least in for the study design. Good for grade 1 spondylolisthesis. The company will tell you got to get a wide decompression. All these new devices, I would advise at least early on, go with the company indications. And it should be, the results are getting published now, and this, again, should be available in about 6 months or so. I don't own any stocking TOPS. I did not have to develop this. This has just been the most effective device that I've seen in my 20 plus years of doing this. And that's it. That's all I got.
Any questions?
Please, Jeff.
So anytime things new come out, there's always the question with coding. When I first started doing Coflex, it's a non-fusion device or it's posterior instrumentation, and obviously we want to benefit everything that happens. This right now is going to be what, a 6999 code with a T code or something, or?
I don't know. What you're saying is very important, right? Because the FDA is going to approve it. So it'll be, at least in theory, available to us, but until the insurance companies agree to pay for it, it'll never see wider use. I don't know how they're going to do it, but I think they're going to try to get a similar work RVU to TLIF, which frankly it is. It's a similar work effort to TLIF. If you look at the timing of the cases, they both took about the same amount of time because this
They
is
don't
so.
care about work. They care about saving money. So since it's not a fusion, it's cheaper, and therefore they're going to be reimbursable less.
Right.
You know, this is initially always been the same thing when Coflex came out versus a fusion. Fusion paid more. You know, why do Coflex?
You know, I always kid the companies about the anterior cervical discectomy with fusion versus the TDR. Said you can debate all you want about the benefits of the total disc replacement, but the only thing it absolutely unquestionably did was lower reimbursements for anterior cervicals. So I don't know the answer to that, but I have to say, you know, from a clinical perspective, I've been very happy with it.
Yeah, I would think so.
Gentlemen.
Yes, Dr. Welch, in terms of where this will slide in, where it will fit, we have now people with spinal stenosis with facet joint arthropathy. So I know there's a lot of spinal decompression being done now in lieu of doing a fusion. In our practice now, we'll recommend patients out for the decompressions if there's no spinal instability. There's flexion extension studies are good, and then we don't recommend the patient undergoing a fusion. We'll say, well, maybe what we look here is for a decompression. In this particular case, this is what, somewhat of a hybrid between the decompression and the fusion.
Yeah, I would say the company selected the indications carefully. I would say those are the best up to grade 1 spondylolisthesis with no pars fracture.
Up to grade 1.
Yeah, the issue is, how many patients do you see that only have single level disease? It's like, right? You never see that. They always have 2 and 3 level disease. The device right now is single level. So, I mean, the way it is now, it's, again, that's why we got the 4 patients out of 100. The majority of those patients had 2 and 3 levels of disease. So it's pretty limited now in what it's going to be available. And you know the company's already working on iterations where you can do fusions or other levels as well. But I'd say it's going to have pretty limited use if you go by what they're going to get FDA for now.
It's like when the TDR first came out, it was single level. Now I'm seeing patients getting 2 level.
It's exactly what 3 levels. That's
right.
Exactly what killed venuses early on. Is as soon as it became available, people were literally doing 5-level venuses. You know, and the FDA was having a meltdown. So.
Right. Yeah, that's same with Coflex. Coflex became not only a very good device from single level, but from multi-level.
Right.
You know, you do say a fusion below it, throw the Coflex above to preserve the adjacent segment.
Dr. Sir, you may want to come up, get teed up. I'll take.
I have a question.
Yes, I'll take as many.
Dr. Mohan has a question.
Yeah, please.
No, I just wanted to know that, you know, in that picture that there is no reduction of the listhesis.
Nope.
So it's basically, you just stabilized it.
That's right.
Or maybe somebody else's animation, not your.
No, I don't reduce. Even when I fuse in position, I don't reduce. But yeah, this is not designed to reduce. Plus, I would suggest if you did it, that would induce another incremental stress on the device. Might not even be the best thing to do.
And what's the length of the screws that you use?
Every standard pedicle screw, you know, it's really just standard pedicle screw. So any size pedicle screw you could buy the company. So the tricky part is they have to go in at a really good appropriate angle, 15 degrees, and the screw heads have to be the same height. And you know, we've gotten, I don't know about you, but you know, I'm just happy when my screws haven't broached medially, laterally, right? The screw heights don't matter. And we've got and I don't go in at 15 degrees unless that's, you know, how it happens to work out. We've gotten a little sloppy, if you will, with regards to insertion of the screws and rods. Here you had to be very precise, and that's one of the reasons why the times took so long. That's one of the reasons why it added a little bit of a struggle to the device. Thank you.
Hello? So I'm gonna cap this off with something totally out of left field for everybody. Just to give you a little background, my name is Steve Sear. I'm an orthopedic spine surgeon. I did my fellowship at the Mayo Clinic. I left the Mayo for the Air Force in 2004. I was actually the chief of spine surgery surgery at Wilford Hall for 6 years and a consultant to the Pentagon and the Surgeon General. So a large majority of my career was spent doing academic level surgeries. I was deployed twice to Iraq during Operation Enduring Freedom and did a lot of trauma surgery. My practice in the civilian world has been primarily complex revision, reconstructive surgeries. I do a lot of anterior, posterior fusions, and I'm still a very active, busy spine surgeon. I practice both in Houston and San Antonio, where I started my career. But I'm going to talk about something totally different. And I'm going to start with some statistics that you may be aware of or may not be aware of. And one of those is that 89% of physicians report feeling depressed about our situation. The same percentage of physicians say that that joy has been stolen by the regulations that we've been bombarded with in our practice. And when you look at the number of physicians who are employed versus those who are in private practice, that number is shrinking quickly. In 2019, 46.9% of us were in private practice, were employed, and then in 2020, very shortly afterwards, it became 70%. So 70% of physicians are now employed by some type of institution. But what's unfortunate about that is two things. One is that the physician misery scale, which is reported by Medscape, says that employed physicians have a 4 out of 5 on the physician misery scale, which means that they're the most unhappy surgeons, at least in that report. So what do we do? What can we do in our life under the regulations of the insurance companies, under the constantly declining reimbursements, under the regulations of government? How can we combat that and still make a good living? Obviously, as surgeons, we make a good living, but how do we avoid continuing to drop in our reimbursements and fighting the battle that we fight? One thing that I think is also very intriguing is that when you look at the percentage of surgeons who are in private practice shrinking, and you look at the amount of cost, it's really obvious why. In 1992, surgeons made double what we make today. Our cost to practice medicine has gone up 39%. Meanwhile, since the Affordable Care Act was initiated, insurance companies like United Healthcare make 1,750% more. Families pay 3 times more for their premiums for their insurance. And as you probably know, especially if you're in private practice, our requests for surgery and procedures are continually being denied. We're constantly battling peer-reviewed doctors, many times from a specialty who has never done any surgery, let alone spine surgery. So all of that led me to multiple issues. And one of them was investments in hospitals. How do you get around that? Well, my thought was, well, I can invest in a hospital. I can have some say. I was the chief of spine surgery for the entire Air Force. But I have a lot of good academic ideas. How do we up the level of private care to the standards of an academic facility? So I thought that investing in a hospital was an answer. It was a great answer. So I invested a lot of my money in a loan in a private hospital, which then went bankrupt. I mean, all of us had to pay our money back because as doctors, we have to sign a personal guarantee. Meanwhile, the owners of the hospital walked off, filed bankruptcy, and they washed their hands. So we're in a unique position as physicians in that there's a lot of people that question the ethics of making money outside of what the insurance company pays us. So that means that we're relegated to what the insurance company pays us, or that we become the employee of some institution. And that's fine. I was an academic for many years. I was in the Air Force for 14 years. I think that's a great and noble profession. I think it's amazing. But for those of us who choose to be in private practice, what can we do? I was so frustrated with my situation that I wrote a book about it. And that book is called, you might be surprised to see, it's not in here, it's called Cutthroat. So I wrote a book called Cutthroat about the trials that I as a surgeon in private practice went through, and all the things that I faced trying to be entrepreneurial and academic simultaneously. It was a really challenging time. So what can we do? Yes, sir.
Include disclosures into.
Oh yeah, I have no disclosures, by the way. No disclosures. So what can we offer? What we can offer right now as surgeons in private practice to make ancillary revenue that potentially could be cash-based is we can do growth factor injections. Well, the FDA took those off the market. The stem cell injections people were doing were removed. You can do PRP. Some people still do PRP in their clinics. You can do hormone replacement. A lot of my first assistants who were mid-level providers that were assisting me in the OR decided to leave the world of first assisting because they weren't getting paid either and go into hormone replacement. So a lot of them are now doing hormone replacement. So if they can do it, we can do it. And then if you look at the numbers of surgeries that are being performed right now in America, there's about 1.62 million spine surgeries being performed, which generates a profit of about $14 billion, which sounds amazing, but 80 to 90% of that is taken by the business side of medicine, leaving us with 8 to 10% of the residual. In cosmetic surgery, though, 4 million surgeries are performed annually, 15 million procedures are performed annually. It generates about the same amount of revenue, but 90% of that money goes to the surgeon. So something to think about. What can we do with our expertise? Can we do anything special that people that are not neurosurgeons or orthopedic surgeons, what can we do that may create a niche for us? And so I started thinking about options. And because I do a vast majority of my anterior surgeries through the spine anteriorly, and I use doctors like Dr. Walks to do my approaches, I had patients ask me repetitively. I've been a surgeon since 2004, so almost 20 years as a spine surgeon. And I've had patients ask me repetitively, hey, while you're in there, can you just do a little nip and tuck, liposuction? And some of that was a jest, but it made me think, is there something we could do? I had patients who I put in braces afterwards that had a very significant challenge getting braced because of the pannus or the abdominal girth that we were dealing with. The bracing was ineffective. And so I thought, well, maybe I could do something to help them, number one, with their back pain, and number two, if I had to do surgery with bracing. And so I started thinking a little bit outside the box, which I tend to do. So let's talk about what plastic surgeons and cosmetic surgeons do. And I know this is a whole different paradigm. It's a definite paradigm shift. But what they do is they do 6 years of training, like most of us, 5 years as orthopedics, 1 year fellowship training, if not 2. And neurosurgery is 6 years. 7?
7 years.
Is it 7 now? Yeah, even longer.
More option.
And so when you look at plastic surgery programs, they'll take ENT, orthopedic surgeons, neurosurgeons after residency. So I mean, how many of you have time to do another 6 years? They'll take general surgeons in some cases, as long as it's the same program after 3 to 4 years of training, and they'll follow that with another 3 to 4, maybe a whole 6 years. But most plastic surgery programs are funded by the Centers for Medicare and Medicaid, so most of their training is reconstructive. They're doing burn care, they're doing microsurgery, they're not doing a lot of cosmetic surgery. And in fact, in their own studies that they publish, 52% of graduating residents from plastic surgery residencies say they feel uncomfortable doing cosmetic surgery without additional training. So they're not really cosmetic surgeons right off the bat, even though they have experience and exposure. A lot of what they learn is reconstructive. There are fellowships. There's an organization called the American Academy of Cosmetic Surgeons that will do a 1 to 2 year fellowship for people with our background, neurosurgeons, orthopedic surgeons, OB-GYN. You have to be a surgeon. Plastic surgeons will claim that they'll train medicine doctors, which they won't, only surgeons just like them. But it's a 1 year fellowship. You have to take time out of your practice, you have to quit practicing, or do what I did. I did a 2 year non-traditional track fellowship. I took out half my week for 2 years, and I sacrificed financially. I sacrificed my time and my comfort, and I put myself back in the student mode after 15 years in practice to do a fellowship in cosmetic surgery. It may seem crazy to some of you, but I think it's been amazing for me. And in the course of my training, I trained with the president of the American Board of Cosmetic Surgeons, and what he taught me was how to do cosmetic surgery of the face, the body. But what I found was that there was a gap in the cosmetic surgery world, a gap in the knowledge of the arms and the legs, and even, believe it or not, in the torso. The surgeons that are doing these surgeries don't have the intimate knowledge of the anatomy that we do from our background. We know the skin to the bone. When we have to deal with fractures and deformities, we have to go from the most superficial to the deepest structure of the body, which means that we have to respect, understand, and be experts in handling musculoskeletal anatomy, vascular anatomy, and nervous system anatomy. So that actually puts us in a unique position to learn these techniques pretty easily. And I found that I was training my professor about the anatomy of the arms and legs, what structures to be aware of, how to avoid the ulnar nerve and and the perineal nerve, how to avoid the popliteal artery, how to avoid the brachial artery, and all of the definition and the origins and insertions of the muscular anatomy, the tendinous insertions on the bone, and how to highlight those muscles, how to redefine and expose and uncover those muscles. I learned that I had a unique advantage over most plastic surgeons and cosmetic surgery fellows. Orthosculpt is actually a technique that it's a proprietary technique that I created in the process of my learning. I learned how to define the muscular anatomy by uncovering the muscles down to the inscriptions of the abdomen, the definition of the deltoid, the triceps, the bicep, the groove, the brachial groove, the bicep and tricep, the IT band where it separates the quad, the VMO, the vastus lateralis, the gastroc, soleus complex, and uncovering those structures allowed us to really create safe, accurate definition in people who could not lose weight on their own. A lot of our patients are women who have had multiple children, have lost elasticity, they've lost the ability to maintain their weight, hormonal cause, age, all those things have weighed in on their ability to be fit and to feel good about themselves. So orthosculpt is the ability to see the muscle and the anatomy deep to the skin because our knowledge allows it. So sorry about the 6 years. I stole a year from you guys that are neurosurgeons, but in our 5 to 7 years of training, we learn a lot about the musculoskeletal anatomy and the internervous planes, the cross-sectional anatomy, the vascular anatomy, all of these things that help us to learn these techniques even easier. But we also can apply the same approaches to from the abdomen to the torso to the extremities to the face. And through minimally invasive techniques, we can learn how to do these procedures, almost potentially creating a new fellowship for our specialties. High definition sculpture, medium definition sculpture of the body. Ideal results are based on personal perspectives, and I'm going to talk a little bit about the body and ideal standards in quotes, of course, for what an attractive aesthetic appearance of a body in the face are. In a female, traditionally, it's written that the waist to hip ratio should be 0.8. In a guy who's athletic, typically we talk about the V taper or the X frame, which is broad shoulders, narrow waist, thick legs, chest to waist ratio of 10, which means the chest should be 10 inches bigger than the waist. But those shapes and the ideal standards vary from region to region, country to country, and even city to city. Social media has recently influenced a lot of, especially the younger generation, to look at themselves more, maybe too much, more intimately, to decide whether or not they need to do something about their fitness. And there's this big push towards being fit and looking fit. So the plastic surgery world, the volume and the demand for these cash pay cases has skyrocketed. It is through the roof. So you look at it, this is an Olympia competitor, a pretty famous one that I know. This is her every day on the right, this is her in competition mode on the left. So understanding where the muscles start, where they end, how they insert, and how they should look to recreate this natural look is a real chore. These are multiple shapes of ideal bodies of females, beginning very significantly, men vary significantly, but in general there's standards that allow all of these people with different body shapes and types to look physically fit. There are some more scientific standards for the face. The 1/5 proportion of the face, ear to ear, the 1/3 proportions of the face from forehead to chin, which creates symmetry and the ideal aesthetic standard for the face, and just understanding a look of what people consider aesthetically appealing. The aging face and a face, even in a fitness athlete or someone who's very lean, can look aged because they lose fat volume superficially, deeply, lose the skin elasticity, so they start to lose the fill and fullness of the face. And you can see these young athletic bodybuilders look extremely gaunt in the face. And so A lot of these patients come looking for things that we can provide as doctors that generate cash revenue for us. Fillers, neurotoxins. And nurses, believe it, all the way down to the RN level, mid-level providers all over the country have built very lucrative practices doing this, and they make more money than we do doing surgery. These cases often will generate $2,000 to $4,000 for one patient in a 30-minute to 1 hour visit. So just something to think about. Even me, when I was fit and I was in Iraq, you look at my face, it's extremely gone. It's not ideal. So these are the kind of patients that will come to you as well for fullness in the face. You can do fillers, you can do implants, and this is something that I also realize in doing courses on implants for the face and the body. You can do hard silicone implants to recreate muscular deformities, Poland's deformity, Poland syndrome for the chest, for example. Deficits in the deltoid from anterior shoulder surgery. We can recreate those natural anatomy proportions with implants. Jawline implants, mid-face implants, chin implants are all very effective. This is a minimally invasive surgery of the face, which looks really natural. It's just tightening the skin through 3 poke holes in the chin and under each ear, but you can really change someone's facial anatomy, shape, tone, and youth with 3 incisions and 1 to 2 hours of surgery. These surgeries generate between $7,000 and $10,000. A male, similar. You see the jawline's really outlined. Blepharoplasty, upper and lower eyelids. These are simple surgeries for us. I do complex cervical surgery. This was the kind of awakening that I found when I was doing these operations. I realized that these are techniques that we are more than skilled to do. When you repair the dura, it's much harder than repairing someone's overhanging lid. So blepharoplasty surgeries are simple operations, but you can really change somebody in a very short time. 3 small poke holes, defining the jaw, the chin, the face, opening the eyes. 6 weeks after surgery, 5 weeks after surgery, 3 months after surgery. And then to the extremities, which is obviously my bailiwick is understanding the arms and legs, but the anatomy we know this anatomy. We know how to protect this anatomy. If the anatomy is injured in the hands of a plastic surgeon who's not hand fellowship trained, they may not know how to handle those injuries. If somebody's doing an abdominal surgery, there are cases I know in town, actually, because I did most of my practice here, of very well-trained, seasoned plastic surgeons penetrating the peritoneum, damaging the aorta by abdominal liposuction when the cannula strays too deep. What would they do? They wouldn't do anything. The patient would die. What could we do? We could potentially, especially if we have exposure experience to the anterior spine, we could potentially get down there and stop the bleed until Dr. Walks or someone like him comes along. Again, lateral shoulder anatomy, medial arm anatomy, understanding where the triceps begin and end, where the empty spaces are, where the peaks and valleys belong. Men, women, this is a surgery. This is done with 3 poke holes in the axilla, anteriorly and posteriorly, and in the posterior elbow near the elbow crease. And you can take a woman like this who was getting married in 6 months, who wanted her arms to look good in her wedding gown. You can take her from that to this, to that, and to that in 6 months. Another lady who just wanted to get the bulk away from her arms, debulk her arms. Another lady who wanted a little more definition, so you highlight the deltoid, highlight the triceps slightly. Breast augmentation, very simple surgery. Another lady who wanted a little more definition. She was naturally muscular but had lost some of her muscle tone as she got older, so we created some definition in her delt and tricep. Took off 600 cc's of fat on each arm through 3 poke holes. Same lady with an anterior view. And just understanding this anatomy, how it's supposed to look, and how do we protect the deep vital structures, or even the superficial nerves. This is stuff we know. We may not be bodybuilders, but we're the people who repair these traumatized tissues. So understanding where the lines of demarcation are. This is a lady who wasn't defined, but she wanted thinner legs, so just debulking her legs. This is also another lady who wasn't defined, but wanted to be able to wear boots She couldn't wear boots because her calves were too big. Her whole life she couldn't wear boots, and so all she wanted was to taper her thighs and legs. This is a lady whose upper body is extremely defined. You can't see it here, but she had definition. Epigastric veins were evident in her stomach. She had extreme definition in her upper extremities and abdomen, but didn't have matching definition to her legs. So she wanted that definition. So you can see this is immediately after surgery, the day after surgery. There's still bruising and swelling, but you can outline the IT band, the vastus lateralis, and this is the quad. You can see the definition of the legs that was definitely not there before, outlining the patella, the VMO, the rectus, the adductor. You can really create a nice aesthetic look. The legs, similar idea in the lower leg. Tapering the calf, outlining the gastrocosoleus complex. Tapering the
How did you do this?
This is all with orthosculpt. It's high definition
Are
liposculpt.
you going to show the pictures of the orthoscope?
Well, I don't know if I have a surgical, but if you look at the picture on the right, you can see those ports. You see the ports medial and
So
lateral.
where'd you put the ports? How do you know where to put the ports?
So
Where did you learn how to put the ports?
I learned most of the techniques on how ports go in, how to do the tumescent, which is infiltrating lidocaine, epinephrine, sterile saline, which is the first step in any liposuction surgery. The difference with orthosculpt is that we follow that with ultrasound. What ultrasound does is it liquefies the fat. So if you know where to liquefy the fat, you liquefy the fat with ultrasound technology under the skin with ports. These ports I picked avoiding the posterior tibial artery, any of the vessels, the perineal nerve, so anything that was in a risky location is where you don't put your ports, you put your ports where the safe anatomy is.
So if she went to a plastic cosmetic surgeon, what would plastic cosmetic surgeon have done?
She had gone to several and no one would touch her legs because they're afraid of the anatomy of the arms and legs for the most part. And when you see liposuction, most of that is done with mechanical removal of the fat. So they're big metal cannulas that are placed under the skin after the tumescent anesthesia, which is the solution of lidocaine, epinephrine, and saline, is infiltrated into the tissue. The problem with it is it creates uneven undulation in the skin, scarring, abnormal appearance of the skin. It definitely avoids the smoothness. So with ultrasound, it liquefies the fat first. And if you understand the anatomy and you can outline the anatomy better, then the results can be more cosmetic.
And what complications have you seen in the cases that you've done, say, for the calves or
I think so far, I've done this for almost 3 years now. So my only complication I've had is one patient who had a medial knee wound, a little port infection that we treated with local antibiotics and it went away. I think the main issue is short term. There's some paresthesias, there's some irritation of the skin, there's a lot of fluid and swelling. You know, these people have to have massage at least 2 weeks to express the fluid that's built up under the skin as a result of the tumescent anesthesia, the liquefaction of the fat, and then the postoperative inflammatory response. And just in general, the seroma that fills any fluid-filled cavity that has a dead space in it. So this is treated with massage postoperatively.
And what do you do if the patient's unhappy at the end of the day?
Well,
one breast is larger than the other, or one thigh is smaller than the other, they come back.
Well, I think, so there's a couple things that I do. I mean, first of all, I think we all, as surgeons, we have patients who are difficult, unreasonable, unhappy. Hopefully they're very rare. But there are patients that you have to screen them just as much as you do a fusion candidate. You have to be really careful about who you do surgery on. When people have body dysmorphic disorder, you want to be careful to stay away from them. People that have unrealistic expectations. We have to screen for that in the process of talking to patients, get a gestalt, a feeling from them, just like we would a spine fusion patient. I mean, I think that these people may be a little bit more aesthetically focused than our spine patients. But our spine patients, with a bad outcome there, we can dramatically impact their lives in that area as well. So, very few people are unhappy. And what I do is I have patients sign a contract of reasonable expectations. And so what that does is it kind of spells out the potential for things not to be symmetrical, not to be perfect.
And from a regulatory perspective, I have a license in the Commonwealth of Pennsylvania to practice medicine and surgery. I can practice anything I want.
Right.
I choose to practice neurosurgery.
Sure.
But so do people have to do a fellowship to do this if they're really interested in doing it?
Well, that's why the whole idea of this discussion is to talk about options, because most people aren't going to set aside 1 to 2 years or 5 to 6 years of training. So what I'm thinking about doing is creating a training program, a certification course for orthosculpt techniques over the course of a year, where I train surgeons who are already well-trained in specialties like neurosurgery and orthopedic surgery, how to do these procedures over the course of a week, train their ancillary staff to do the fillers, the Dysport, the Botox, if they're interested, and train them as well, so you can create ancillary streams of revenue in your practice if you're interested. But that whole program is going to probably start in October, November of this year. So just more examples of the results. But these surgeries are very rewarding. For me, I'm 50% right, 50% left brain, and I like the creative aspects and the immediate gratification from these cosmetic procedures just as much as I love my happy spine patients coming back after years of inactivity or being unable to function, having their life given back to them. So for me, it satisfies both sides of my brain. I've been very, very happy with the results. I feel like my training made a huge difference, and my learning curve was really quick because of my experience as a spine surgeon for almost 20 years. And I think this is something that we can do. It's definitely outside the box thinking, but we are probably always going to feel the pressure from regulation. We're always going to probably have our reimbursements reduced as time goes by. We just took another hit. Medicare reimbursements just got hit one more time. Our cost of practice is through the roof every year. My overhead goes up every year. My staff is demanding more money. Whether or not we made money during COVID or not, they want a higher salary. And so this is a way that has actually helped buffer that strain financially on my practice. And my demand for cosmetic procedures, and believe it or not, I have people flying from all over the country, and one of the main things they say is, I love your background. I love the fact that you're an orthopedic surgeon and that you do spine surgery and you understand complex, intricate surgeries more than any of the plastic surgeons I've talked to, and I felt more comfortable with your background than I would with any plastic surgeon. So a lot of them have come specifically because of my background. So it's definitely outside the box, but it's been very lucrative for my practice. It's been a way. I actually have carried some of my spine revenue with my cosmetic revenue, and it's been really good in our practice overall. And I'm booked past September, months and months in advance.
So body sculpting, it's not brain surgery. I think
Right.
that's what we're saying. Or
It's
even
true.
spine surgery.
It's not. It takes some degree. I mean, you have to learn the techniques.
Of course.
But the fact that we know that the anatomy is everything. Whether it's a new procedure you've never performed in your fellowship or in your practice, you know how to do it because you know the anatomy. You know the basic tenets of what we're doing. I mean, the fundamentals are there. And so if you learn these techniques, you can use that in conjunction with your knowledge to really do things I think that can be revolutionary in surgery and create streams of revenue without the force of the constant decline in our reimbursements.
Questions that I already asked so many.
So what's the durability? What do you tell patients about the durability of the procedure? Like how long the scalp lasts?
So anytime you remove fat, it's gone permanently. It's extreme. Adults don't create new fat cells unless they become so obese that they get into a position of hyperplasia. Hyperplasia for an adult is extremely rare. Most of us have hypertrophy and atrophy of fat based on our weight. So if we gain weight, it's typically our existing fat cells are growing in volume. When we lose weight, they're shrinking in size. So you have to be 300, 400, 600 pounds in order to create new fat cells. Most people are gaining weight by volume alone of the individual fat cells. So when they are removed, they are permanently removed. And that's what has brought people to the idea that maybe when you remove it here, it goes here, because what will happen is they'll gain weight, but it won't be as visible where you removed it. It'll be more visible where you didn't, because you have less fat cells here than you do here. But it just tells you just gained weight. So you just need to lose weight again. But a lot of patients understand that, and just like everything else, you have to just kind of lay it out for them. Explain to them the expectations, the ability, how far we can go with these things. You have to give them realistic expectations. You have to explain to them what it can do, what it can't do. You can't take someone who's extremely obese and turn them into a fitness model. You just can't. You have to tell them, I can only go so far with this, but we can make proportional changes in your body that even weight loss won't. Because what we can do, for example, in someone who has a wide waist and narrow hips, you can transfer fat to the hips and to the buttocks. You have to do it above the muscle so you don't give people fatty emboli that kills them. And so when we do that, we can change the proportions of the body in a way that weight loss won't. They can lose all the weight in the world, they'll still be wide-waisted and narrow hips. So you can change the proportions in a way that even fitness can't. But you have to explain it to them in a way that makes sense and give them expectations that are realistic and achievable.
of substances do you use to liquefy the fat?
So the fat it's done with a machine called Vaser. So these machines are very expensive. That's why the vast majority of plastic surgeons don't have them and don't do the liposuction this way. That's why you'll see a lot of uneven results. I do a lot of revision surgery on those patients. But it's called Vaser, V-A-S-E-R, and it's an ultrasound that creates an energy, cone of energy. It's about 360 degrees of energy that literally liquefies fat, and it can liquefy scar. So when we do it, when we're revising, we use it to break down scar, we use it to break down fat. And then you come in with your liposuction tools to sculpt, and that's when your knowledge of the anatomy really kicks in.
So do you use any kind of biosalt or anything for all that fat that maybe it's still floating in the system and go to the liver?
No, we suction it all out. So it's suction out. It's once it's liquefied, it's suction out with liposuction cannulas, and then we create definition where we want. And then usually I'll follow that with radiofrequency, internal radiofrequency, which tightens the envelope of skin by shortening the fiber connective tissue network from the skin to the muscle. So that makes them look even more defined, more taut. And then if you liquefy that fat, you treat it with antibiotics, you purify it, and you can transfer it to the face, the lips, the buttocks, the breast, to the chest, the delts. I mean, you can do a lot with the fat.
That's through injections or through
Injections. It's injections.
We're gonna consider this your disclosure page.
Well, that's just those are my companies, yeah.
That's a disclosure. So
Okay.
we're gonna assume you have something to do financially with these companies.
Oh yeah, well I own those, yeah. That's my practice.
That's your disclosure, so
Yeah.
he has met the disclosure requirements of the fund. All right.
Yeah, but for the liposuction portion of this, I have no disclosures.
Very good. Thank you.
Thank you.
Okay, so to conclude this session, please go to the general meeting. There are different topics, and I think the next one is the lunch seminar. We'll see you tomorrow.